Well, good morning, everybody. Michelle, and can you hear us now okay? Excellent.
Perfect, thank you.
Wonderful. Welcome, everybody, to our second Health and Wellbeing Board of the municipal year. Before we start these proceedings, may I bring to your attention some housekeeping matters. There is no expected fire alarm today. So therefore, if the fire alarm sounds, please follow the emergency procedure. Well, the easiest thing is follow Elliot. Okay, he will guide us to where we need to be outside. Um, so the meeting will be broadcast, as we know, live on the internet and will be capable of subsequent viewing. By entering the Warspite room today and during the course of the meeting, committee members are consenting to being filmed and to use the use of those in recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it's switched off when you're not using it. And the magic thing, can you please turn your mobiles to silent? So moving to item 1. We have any apologies, Elliot?
Yes, thank you, Chair. Apologies from Councillor Carlisle. Councillor Harrison is substituting today. Apologies from David Haley, Interim Director of Children's Services, and apologies from Gary Woolbridge, Strategic Director of People. Thank you, Chair.
Gary's on holiday, so we'll forgive him. But Emma, you're very welcome. All right. Right, so moving to item 2. Any declarations of interest. Natalie.
Thank you. Item 7, I am employed by Four Greens Community Trust, which is the Wellbeing Hub, which Ruth, I think.
Thank you for letting us know that. Not a problem. Okay. Chair's urgent business. I've not got any. No. So we'll move on to item 4, which is the minutes from the last meeting. Have you all managed to have a read through? Those of you particularly that were here, that's always useful. Any alterations that you think, oh, I didn't say that? No? Okay, well, I'll get them signed as a correct record. Can I have a seconder, please? Thank you, Tony. Right, so questions by the public. We don't have any. So we'll move on to item 6, which is the Carers Action Plan. Can I ask Emma Crowther as Head of Commissioning and Kate Latimer as Commissioning Officer and Lee Sorey as Improving Lives Plymouth? Is that all the gaggle? Yes, that's all the gaggle. Can I say a big welcome to you all and thank you very much. And who's going to introduce it?
Thank you, Chair. So, yes, thank you for welcoming us today. So Kate Lattimore is our Commissioning Officer who leads on our carers work and is going to talk us through the practical steps of how we do this and the position for carers in the city. And Lee is the Operations Manager for Improving Lives Plymouth, is one of our key delivery partners in this space and works every day with a whole range of our carers. We'll also be referring to Live Well, and I can see Michelle's joined us. We work very, very closely with Live Well in this space. So we're going to talk you through, as the first slide says, the data and figures, the pressures for our carers, who they are in our city, and particularly what we're doing to support them. Now, I'm driving the slides, so that all the hard work will be done by these two. So brace yourselves. I shall hand over to them now.
Is that on? Yeah. Okay. Yes. Morning, everyone. Hi. Yeah. Nice to see you all today. Yes. So obviously Emma's done the introductions, and you can see from the we've gone on to the second slide. But I'm just going to start off talking about some of the data and figures about our unpaid carers. So we had the 2021 census. The most recent one that's obviously they carried out every 11 years, and it showed us that just under 24,000 people describe themselves as a provider of unpaid care. So, and that's using the definition that an unpaid carer may look after, give help or support to anyone who has a long-term physical, mental health condition, illness or problems related to old age, and it doesn't include anything that's done as paid employment. The census figures also within Plymouth, it showed us that the number of hours of care that people deliver has increased. So, carers are doing more. There's also lots of research and data from national organisations such as Carers UK that says that the work that carers do, the care and support that they provide has been equated to about £162 billion per annum, which is more than the NHS budget. And we know that currently all the workforce pressures that there are within the health and care system, I mean, in particular around the care sector, means that it's, the role of our informal carers is so important to the health and social care our economy, and kind of underpins the health and care system. And then just a little bit about some of the data. So this is just kind of like demographics, and this relates to carers last year that were known to services that within the services within Plymouth. So just to give you a bit of an understanding of kind of like the ages, the ethnicity. So ages, that kind of like reflects the national picture. So most carers, the majority are actually working age between 26 and 64. However, we have lots of carers who are aged, you can see from the data that that nearly 40% are over the age of 65, and then 5% 85. So that gives you an indication. Ethnicity, I mean, obviously that's going to vary because this is Plymouth, and although our kind of ethnic diversity is kind of changing, it's still predominantly, white is the main ethnic group, and it kind of reflects that. And then sex, this is similar to national, so it's mainly women that take on the caring role, but so this is about 70%, but men do too. So just going to talk a bit about the pressures carers face. So many people are really willing and happy and want to be a carer because they feel it's the right thing to do, it's their family member, it's their loved one. But notwithstanding that, there are lots of pressures that I'm sure people can kind of like, can probably see. There's lots of evidence. So there's the annual GP survey that's taken, and it looks at people who are unpaid carers and carers, and people who are unpaid carers, they always report kind of higher in terms of things like depression, anxiety, stress, physical illnesses. And Public Health England have looked at some of the GP survey data and even recommended that caring be a social determinant of health. And then carers, as I said, more likely to have stress and anxiety. Because they generally, carers can prioritise the person that they're caring and supporting, so they neglect their own health and well-being, might not go to their medical appointments. Personal relationships can be impacted as well because it puts strain on relationships. And then also cost of living crisis, which we're all aware of. It is pressure on most people, but carers in particular, because they can have additional expenses such as, you might have to have equipment in the house for the cared for person, so using more electricity, heating might need to be used more. Carers can be impacted by not being able to be part of the workforce. They can't work as much. They might have to rely on carers allowance, which is not a very, generous benefit. And then just going on to who are carers. So, so similar to the census definition. So it's people who provide unpaid help and support on a regular basis to partner, family member, friend. It can be practical help, it can be personal, physical, emotional support. And also, I mean, statistics say 3 in 5 people in the UK become carers, and I'm sure there's people probably in this room who are a carer, who've been a carer, or who very well probably will be a carer. And then it can be sometimes, I mean, especially in the health and care sector, we find there's a bit of confusion. Like people can say carer when they're referring to a paid carer, but I mean an unpaid carer is something quite separate, and can be known as unpaid care, or friend and family care is what we do. And then some people can spend many years caring, like parent carers can have a child with a disability. That caring role will probably be throughout their life. Some people it can be, like result of an accident, bomb. You're a carer, all of a sudden your partner had a stroke. So just the next one. Thanks, Emma. And then often I think it's important that many people don't see themselves as carers they feel they just see themselves as someone, you know, that's their role, that's, you know, it's my mother, it's my husband, it's my, you know, child, it's my friend, it's my neighbour. They don't see themselves as carers, and it often takes time for people to kind of understand that they are a carer. And I think it's really important that we in the health and care system, we make sure that that we always have to be care aware and think carer, because if you go to the next one, because it's important to identify carers, because when carers recognise that they are a carer, it means that they can be eligible to have support and to have services, etc. So support for a carer can kind of benefit the whole family. It means that they're better able to, you know, to carry out their caring role. It can help them access, you know, like different services, like Lee's going to go and talk about. Go on to the next one. So, and then I've just talked a bit more about, referred more to adult carers, but we've got many young carers within the city as well. So we've got carers as young as 4 years old, you know, that reach obviously right up to the age 17, which is the definition of the age of young carers. And there's just some definitions there. So under the Children's Act, under the Care Act, and so it's, you know, and the highest number recorded for young carers in Plymouth schools was over 900 in 2020. So we do have a lot of young carers. Yeah.
Just to chip in on this, as you'd expect, as I was the Children's Commissioner for many years, I remember going to visit a group of our young carers some years ago and saying to them, what do you want to do when you're adults? What do you want to be? What's your aspirations? And they said, well, I'll be a carer. And that might be the right thing. It might be absolutely their choice, but I was really struck by their absolute, and they weren't angry or upset by it. There was just a total acceptance that that was their lot in life, and it stayed with me ever since. And that's our particular challenge for our young carers, as Kate's described, really, is helping them to recognise that they are young carers, particularly if you've done it from the age of 4, and their entitlement and their support. And it's so important that that generation of carers has the opportunities and their sort of expectations are recognised as well. So it's a particular sort of passion for my team to identify young carers. As Lee will go on to talk about the support that's available, but actually we've got to get it right really young.
Just to say another thing around a 5-year-old that I met a few years back, and I was talking to them about activities during their summer holidays and what had been exciting and, you know, what was good. And this young girl said to me, she was 5 years old, and she said the best thing that she'd done was a first aid course. And it really struck chords for me that, you know, we need to make sure we're getting things right for young people in our city. Thank you.
And we know that those children are often, they won't recognise that they're carers. They will often, as a family, be quite frightened to come forward. They will fear that this will open a door to social services, to bringing sort of problems to the family rather than support. And, you know, a real sort of statement we'd want to make is to urge people to do that. There is support, non-judgmental. You know, if we can help to keep that family, as Kate's described, resilient, and look after them and wrap around them, that's what we want to be doing. We don't want to be going in and, you know, separating families like that. But that's a genuine fear for families, that if you admit to the level of caring that your children are doing for you, and the reasons for that, because often it's linked to mental health or substance misuse, that's just so important, isn't it, that we get that right.
So just going to go on just to talk a little bit about the actual law and the national guidance. So there's a few statutory obligations for us as health and as the kind of health and care sector. So there's the Care Act that I'm sure people are aware of, that was 2014, and that gives local authorities duties to assess people's needs and eligibility for care and support, and carers were given equal footing within that. We've just talked a bit about young carers, Children and Families Act, which gives young carers and parent carers additional protection. We've got the NHS long-term plan, which had several actions about how carers will benefit greater recognition, the NICE guidance, and then last year, for the first time, under the Health and Care Act, the NHS now has duties to support carers around specific areas, mainly around in hospital discharge, and then also it introduced the power for CQC to assess local authorities, which will include duties around carers.
Just to say that's going to be really important. So the new assessment framework, assurance framework for adult social care has a significant section on carers. Rightly, we really welcome that. So we're going to be pushed hard as a local authority with our ICB partners, with our other health partners and social care partners, to really demonstrate how we're getting this right for carers, and we really welcome that. Actually, it's a really welcome change.
So just to go on a bit, so what are we doing in Plymouth to raise awareness, recognition and support of our carers? So one of the things we have is, people might be aware, we have what's called the Carer Strategic Partnership Board. So it's a partnership board that consists of all the kind of like key stakeholders in the various health and care organisations. We have voluntary sector, education that come, and we meet quarterly, and we have some fantastic carer reps who really dedicate their time and effort. And we have the creation of a Plymouth Carers Action Plan. So that has and the key priorities in that are taken from feedback from carers. So that may be through the statutory adult carers questionnaire, feedback from the carer service that Lee's going to talk a bit about, talking to carers. And also it will be informed by things like the statutory requirements, like the long-term plan and what's in the Health and Care Act. So we also have things like we have the Devon Integrated Care System. We've got the Devon Carers Leads, and that's working with our partners across Devon, Devon County and Torbay and NHS. And we have what's called we've got a commitment to carers as well, which is a key. That we really want as many organisations within across Devon to sign up to, and it's got 7 guiding principles and actions for organisations to demonstrate what they do to support carers. Just a little bit about some of our achievements that we've had. So we created a carers passport working with colleagues in UHP and Live Well, which is and St Luke's and Improving Lives Plymouth. And the carers passport it's kind of got dual purpose. It's a recognition card. So if a carer shows that in the organisations, it means that they're eligible for certain benefits and discounts. It's also an emergency card. So if a carer had an accident, and it's got the number and who they'd call. We worked on delivering a hospital-based care recognition service, working with our colleagues in Devon and in Cornwall about how we ensure that we raise awareness amongst the hospital staff about carers, that they're involved in discussions, to ensure they're involved in discussions about their care for what's wellbeing and discharge plan. Contingency planning processes. We've worked to ensure that that's streamlined and it's embedded to the Eclipse system. We had the Mind the Gap programme, which was working with colleagues in like the Race Equality Council, the Devon Chinese Association, just to think about how we can ensure that our services that the ethnic minority communities are more aware about carers and that services, etc. So we did things like translation of information. We did training of community organisations that work with ethnic minorities as trusted organisations. We created ESOL learning that focus around health kind of terminology. We reviewed carers breaks and provision that's taken place, new policy in place. And then we've got our priorities going forward is we've got a project around how ensure we support PCN, so all GP practices are kind of more care aware, and steps and how we can support them to do that. There's a neat task force. I mean, Emma was talking a bit about the aspirations of young carers in education, because they often, unfortunately, might fit into the NEAT category. So there's a partnership between the Young Carers Service and Assessments with that task force. Caring for Carers are developing a Carers Ambassador reference group. So I'll just pass on to Lee. I know we haven't. Sorry.
Okay, so I'm going to talk a little bit about the service provision. It was probably helpful if I just say that I did manage the carer service for 10 years before I stepped up into operations, so I have a real passion for this area. As it says on the slide, the Caring for Carer service is provided by us, the charity Improving Lives Plymouth, and we have been leading on that for 12 years now. So we provide support to anyone who's over 18, but we also link in with the Young Carers Service. And we also have, there's another slide later, but I will talk about that now, is that we have a service that we got funding for 18 to 25-year-olds, so that's our young adult carers. And the Carers Trust funded us for 2.5 years for that, and that will be up in March next year, but we are currently looking for further funding for that because it's been an excellent opportunity and been amazing for the young people in the city, because they like to interact in a very different way. They don't want to come to support groups where they're having tea and coffee. They want to be somewhere where they can play pool and have a good time. Supporting carers in all areas of their caring journey is something that's really important to us, and this includes before caring. So I'm just going to run through a few things of how we do this. So we advertise carer services to support people to recognise themselves as a carer at information and health and wellbeing events. That was very challenging over COVID times because obviously you couldn't get out and do that, but we are now starting to get back into that and being able to promote the service to people, because as Kate said earlier, people don't recognise themselves as a carer. They always say, but I'm their husband, I'm their wife, I'm their friend. And it is just about making people understand that we're not going to interact with them in any way that they don't want us to. And in fact, if they just register with us as a carer, the very least they'll get is our newsletter and a telephone number that they can contact if they have any difficulties. It's as easy as that, really. Information and advice to help people decide if they wish to interact with carer services, and the support that's available. And as I've just said there, that can be as little or as much as they need, from just having a contact right the way through to having a full assessment, and us working with them and their cared for person and any other professionals that might be involved in their life at that time. Supporting health professionals to understand who is a carer and what support is available to them. So that's quite important, really, because I think that's the best way of us getting carers into our services to help them get the support that they need. And as I've said, some people don't need very little support. They just need a contact number on the occasions when they do need support. And if their caring responsibility is going to expand and change, they probably will need that in the future. So becoming a carer, once someone has registered with us and we've identified them as a carer, there's lots of things that we can do for them, and that includes things like training opportunities, having an assessment, information and advice to support all the areas of their caring, and then once they've interacted with those, we can then look at supporting them to live as a carer, to have their own lives, but also have something that supports them with their caring responsibilities. And for us, that would include reviewing their situation regularly, and enabling them to come back to the service as and when they need to, because sometimes things change very rapidly, and you can't wait a year for an annual review. And this is what we say to carers is come back to us if you need us, because you need that port of call. We also will make information and advice calls. So if we've said to someone, try this, so maybe we've done a support plan with someone, we've said to them, try this, we would then book a call in with them to make sure that firstly that they have done what they said they were going to, because very often the caring responsibility takes over and then they don't. So we might then step in and actually do some of those things for them. There's support groups. I think we've got 12 support groups now for some generic, which are for any carer to come to. Some of them are for the carer and the cared for to come to. So for instance, we have a dementia carer support group where the carer is in one space and the person living with dementia is in another, being supported by professionals, so that the carer can actually have a couple of hours to themselves, but they are still very close to the person that they care about. And that was really important to that group of people, because when we first set that up, we didn't have a space for the person living with dementia, and we didn't see the amounts of carers we see now, because they just said to us, well, I can't leave them at home. There is nobody to be with them. So, it's really important that we set things up in that way. There's also some financial support. So, we have budgets from the Carers Trust. We have support from the Household Support Fund. So lots of areas that we might be able to find. And also, we would work with people. So, for instance, if someone has been a veteran or they've worked in schools, there are lots of funds out there that you can go into for them on their behalf. And of course, lots of people don't know that those things exist. And these would be for things generally like white goods. We hear a lot of, my fridge is broken, I can't afford another one. So things that would be supportive to them. Training, we run training opportunities for individuals, and that tends to be based on what carers are telling us they need. So, for instance, if we had a lot of people saying, well, I have to do a lot of lifting and handling, moving and handling, sorry, we might then look at putting something on centrally for people to come to. But we also have, fun training events and activities as well, because I think that's really important. We've got links to free legal advice, so half an hour legal advice for people, because very often our workers will be confronted with situations that we can't support the person with because we don't have that legal background. And that does get accessed quite frequently. And I think it's important because a lot of the time, there are legal matters within caring that need to be dealt with. And I think if you can just have half an hour free with someone, that's really useful. Working and caring, as we've talked about earlier, we've got good links with the DWP and the Job Centre Plus. And we are currently in talks with Carers Trust around how we may be able to have a 3-year contract with them to work with, alongside the lottery, to support carers in Plymouth and employment. So, and when caring ends, which sometimes it ends because the person has got better, and they're the ones that we enjoy. Sometimes it ends because the person has either died or has needed to move into a care home or what have you. But we will work with that individual after that end for up to 6 months. And that is anything really that they need us to support them with. Because sometimes if someone's been caring for 20 years, 30 years, that has become their life. So they don't really know what's available to them anymore. So we would support them to do that. Next slide. Oh, no, not next slide, sorry. So the service is delivered in a co-productive way. So we work with our carers to look at what service provision is delivered. We have care representative volunteers on the Care Strategic Partnership Board, which is really invaluable to us. We have focus groups, social media polls. We ask people their views at events or in our newsletter. We've got a Have Your Say page on the ILP and the PCC websites. And we also do annual monitoring and evaluation in lots of different arenas. We undertake, the carer service undertakes assessment on behalf of the local authority. So we have to make sure that all of our teams understand the Care Act, because obviously that is a legal requirement and a statutory obligation. So all of our teams are trained in those areas. Raising awareness and recognition of carers and the value they provide. The Caring for Carers team offer carer awareness training alongside young carers services, so that we can support professionals to understand the best ways to support carers. And actually how that carers awareness training ends is, please just refer them to us and we'll do the rest, because a lot of the time professionals are so busy that they want to do that work, but often it slips through the net. So if there is a very easy referral way into the carer service and then we do the rest of the work, we find that people are much happier to refer people in. We work in partnership with Devon Carers and Cornwall Carers services on University Hospital's Plymouth work. In Plymouth we've got 2 workers in the hospital who are called Carers Hospital Liaison Workers, and we're currently doing lots of work around that to to try to, you could probably understand that having 6,000 staff is quite difficult to implement awareness, and we're really working hard to try and work through that. In fact, yesterday I shadowed a DCM, so a discharge manager, just to see their work and how we can implement things into their IT systems that will help us to make better referrals. How am I doing for time? Next, please. Yes. Okay, so these are a few of the stats from 22-23. I won't go through them all, but they are there for you all to have a look at. I suppose it just gives you an idea of how many people come into the service and how many people we support with certain types of things, and also, not everything is local authority funded. That we do find money from other places, and we try our hardest to do that because we know that we need to bring more money into the city that isn't coming out of main pots of money. So we do try to do that. Lovely, thank you. As we said earlier, we work very closely with Live Well, and we use the same Eclipse system. So what I would say is that adult social care are definitely aware of the carers service. We receive a lot of referrals into the team through the Eclipse system. We can work alongside all of those teams that are mentioned up there, and if joint assessments are needed, we would work with them. So the carers workers would do the assessment for the carer, and the adult social care workers from Live Well would be doing the assessment with the cared for person. We don't see that very often, and I think that is probably because carers often need a space where they can be very truthful and honest. And when you're sitting with the person that you're caring for, it's very challenging to be able to be truthful about how things really are for you. And actually, I think I would prefer that we did separate assessments, because then we can actually prepare a support plan with that individual that is real and will support them well. Recognising and supporting young carers. So Kate did talk about young carers earlier. So we've got Time for You in Plymouth, and that's 3 organisations. So that's Youth Service in Plymouth City Council, and they run groups, and Bernardo's, and also Hamo's House for Hidden Harm, as Emma was saying earlier. The adult carers service are also part of that Time for You, because there's obviously a time when someone stops becoming a young carer and will need to transition into young adult carers services, and that's when our young adult carers services becomes a real positive, because we've been able to link our workers into these workers, and then we've now got this very smooth transition, whereas previously that wasn't working as well as it does now. And I think the Eclipse system has also helped that, because youth services and adult services use the same systems, so we've been able to make sure that any transitions work comes over early, and we can start working with that individual earlier. As I've said, we have the Young Adult Carers Service, which is paid for by the Carers Trust, and it has been a very good addition to carers services in Plymouth. With schools, PCC have a Young Carers Champion within education, Young Carers Education Support Team. They work with schools to support the identification and support for young carers. And many schools in Plymouth have their own young carers leads, who offer support and activities. And the young adult carers workers have been able to link in with those workers in the schools. And there is a meeting that happens regularly that they all attend. So again, it's very good that people are in the same arena, because you're able to then match people into the services that they need going forward. I did have a case study, but actually what we decided is that we play you a video, because I think it's much more powerful, and this is about the Young Adult Carers Service.
Improving Lives Plymouth Young Adult Carers Group offers a service that puts the carer at the centre by giving them a voice and a sense of identity away from their caring role. There are no barriers to engaging in the service as long as you are providing some sort of necessary unpaid care for someone in your life, friends or family, and are aged between 18 to 25 in Plymouth.
We support individuals who care for those with drug and alcohol addictions, mental health issues, physical illness and disabilities. The support offered and engaged with comes in many forms such as one-to-ones, monthly drop-ins, group activities, check-ins, which can be via text, phone or Instagram.
They always make sure everybody's included. They're always there if we need them, and they're just so easy to talk to. And it's a really lovely group. It's a really nice place to come. It's kind of nice to just someone actually has an interest in you, whether is caring for you, instead of just feeling like you're on your own and you're constantly caring for somebody else, and you just feel like you're on your own with it. Nobody else understands it until you come to this group, and it's like actually there are other people out there that are going through the same as me.
As well as being a service user and a volunteer, it's certainly helped my mental health. Without it, I'd just be stuck at home, pretty isolated, unfortunately. So the service has been so helpful. It's getting me out of the house and just giving me that little bit of care that I need, as well as giving care to others who need it. So it's very important, I think. If you can't look after yourself, you can't look after others.
We try to remove as many financial barriers as possible and provide food at every drop-in activity, support with transport and offer a variety of activities such as theatre trips, meals out, escape rooms, bowling and laser tag, to name a few.
We work with local schools, colleges and universities to identify carers who may need our support. To support the individuals, we work alongside other services.
Young Adult Carers are a friendly and supportive group that gives new members a warm welcome and an opportunity to make friends with like-minded people, offering them a chance to be themselves away from their daily responsibilities.
I remember when I came to my first drop-in, it was a little bit overwhelming at first because there were quite a few people, but once you get into it, once you start getting to know people, it's so relaxed.
It's really lovely to see like new faces every week. There's always new faces every week. It's really nice to know that people out there that are in the same situation as us can come out and just chill out with people that actually know what's really going on, because it is quite hard to explain to somebody who doesn't really know.
We take a holistic approach to the support we provide by working with individuals to come up with a support plan, identifying next steps and equip them with information and advice they need.
We support young adult carers to get back into work, education and to try new experiences, building their confidence, resilience and self-worth.
This group's definitely changed a lot of us. It's definitely helped us become more confident. Like I would say like 4 years ago, I would not be as confident as I am today. I don't feel alone anymore. I don't feel like I'm an outcast. It is really nice to just be in such a nice, calm environment where no one's going to sit there and judge you, and everybody understands what you're going through, and like we all help each other out because we know how difficult it can be. Everyone here is so lovely. They really are.
So there you go, that's us. Hopefully that's given you a flavour of the work for carers in the city. We think they're heroes and they deserve our support.
Can I say a big thank you to the three of you for coming along and talking about this. And certainly I think that video is very, very powerful. And I think we need to think very seriously about playing that in full council. I feel that strongly. It needs to be done. So we need to sort that out. Do you mind? I'm going to let you come in now.
Thank you, Chair, and thank you. And I mean, this report just lays out the extent of the issue, and I really, you know, the amount of work that is done to support people in this role. And just, you know, you think you kind of understand what it's like. And a couple of years ago, my husband had a really serious life-saving operation, and I became his carer, you know, because there was some, you know, he couldn't do most things for himself. And suddenly, and I thought, oh gosh, my life just shrank. And that's the thing that I remember from it. You know, fortunately, touch wood, you know, he's fine and and it was only a very short part of my life, but it was suddenly my time wasn't my own. I couldn't do what I wanted. And I know it sounds really obvious, but actually when it happens to you, you suddenly think, oh, crikey, this is the impact. And so especially looking at the young people there, you know, knowing that that's what that's done to them, to their outlook and what they can do. And there's some of those statistics in here that really, you know, actually what we're saying is somewhere around 1 in 10 people in our city is a carer. And another statistic that's really stood out to me is the gender balance. So more than 2/3 of those carers are women. And I know later on we're going to talk about Ruth's report. And one of the things that comes out in that is how women in the city are not enjoying healthier, I can't remember the right terminology, you know, healthy life expectancy is going down. And I just didn't know if there's any kind of correlation or any connection between those things. And we know as the society it tends, you know, the burden does often fall on women, and what kind of impact that has then on their career, their own health, their, you know, social life, everything is really, really impacted by this. I just wondered if there was any connection between those two things. And do we know if, because I don't think the breakdown is here, are the people they're caring, do we have a breakdown on the gender of the people that they're caring for? I was just quite interested to see what the correlation was there. Thank you.
Emma, is there any sort of data that we can forage? I'm not saying we need to have it immediately, but if there's something that we can forage and come back to us about. But Lee, you've got an idea?
Yes, I think that will be in the system, so we should be able to do that.
Thank you on that. One of the things that, in fact, I think you answered it very clearly in the end. I'd written down about Mind the Gap and about the Chinese community, because we know that they're one of the most difficult in Plymouth. But in fact, Kate, you then followed that up with something. So that was really great to see that we're engaging with them, because there must be a fair number of the families there that affects. So to me, I think it was, how do we make sure that we're promoting the carer service within the City Council and within this Health and Wellbeing Board? I think that it's very obvious to some people how we're going to do that. And I think I've got more faith in the fact that what you've shown us today is showing that how we're going to do it. And obviously I'm interested in the fact that it'll be in that CQC assurance thing. So that's really great. One of the things that I think, I mean, Ruth will be no doubt mentioning at some time, is are we making sure that as soon as we've got the information about flu and COVID jabs, that we're getting that out there on, because, you know, it's the obvious thing that if your carer's not had their jabs, then, you know, they're going to end up in a pickle if they get an illness, aren't they? So I think it's just catching up with that. Did you want to say something on that?
Yeah, all the way through COVID, and obviously as we go into this winter season, there are specific groups around carers and vaccinations, and there's specific support as well to help with carers being able to take the time and be able to get to vaccinations and bringing vaccination opportunities to them. So we work very, very closely with ICB colleagues on that across the whole of Devon. So all those mechanisms are in place.
And I think the thing that comes home to me quite often is that we've got to go down the digital line all the time. We really, really have. But there are always going to be those that are digitally excluded, and we need to be making sure that and Lee, no doubt you have a very clear line on how to do that. And I'm really pleased to hear that you do the newsletter, because I can appreciate, whilst it could be an e-newsletter, there's also going to be those that you're posting out. So
yeah, so we send an e-newsletter every month, and then twice a year we have a paper newsletter. And the reason that is only twice a year is that the cost to send out to nearly 8,000 people who are registered with us, it's just a huge cost. So, but it is absolutely needed, because what we find is that sometimes that's the only way that people get information and then start to interact again. And we do it at times of year so that we can advertise Carers Week, which is in June, and then advertise Carers Rights Day, which is in November, so that we can get as many people to those events as possible. And we do have the vaccinators coming to Carers Rights Day.
Excellent, thank you. John, you wanted to say something?
Thank you, Mary. Briefly, and following on from your excellent report, carers fall into many categories, but it strikes me that there are two categories that stand out. One are carers who actually live with the person they're caring with. I mean, this might be a child, this could be a son or a daughter, it could be a spouse or whatever. And those who actually don't and go in and give care. I mean, I suppose I'm a carer for my mother, but I go in, she's got other carers as well, but I can actually leave and escape. And I think it is rather different potentially, and what percentage of people who say they're caring would actually be living with the person they're caring for? Because it's an entirely different perspective, I think, if you're living with someone all the time.
My mind is whirring to see whether we've got something somewhere that would give us that information, but I will take that, and I'm sure that there must be a way of us being able to understand that, and if not, then we might be able to implement something so that we know that going forward.
People who live with people they're caring for are probably more prone to issues, problems. I mean, it's entirely different from going in and leaving, isn't it?
And I would think a lot of them probably don't recognise themselves as carers. They probably just accept they're there, they're living in a family situation, it's part of the family. So they might be those people that think, oh, no, they don't recognise themselves for what they are. So I think that's an interesting perspective. Natalie, you wanted to come in.
Yeah, and thank you for the presentation, and it was very hard hitting, and it brings it home, the variety of carers and also what's being done, which is fantastic. I'm just going back slightly on what you were saying about contacting or making contact with carers, and Councillor Aspinall said about digitally excluded. I'm pleased to hear that you make phone calls because so much things are digitally. There's people that aren't digitally excluded, but actually are very uncomfortable about putting their details online. So how do you engage and for example, do the assessments or find out, are there opportunities for people to have those phone conversations rather than everything having to be, oh, you've got to put all your details online?
Yeah, so there's a few ways that people can register or interact with us. So there is an online register as a carer, which does get used quite a lot, but it's generally from a certain age range, and our older population tend to want to telephone or and many of our assessments, I would say 99% of assessments are taken over the telephone. We pre-COVID, all of our assessments used to be face-to-face. But actually, COVID helped us to understand that people don't necessarily need it in that way. And actually, most people are happy to talk to you over the telephone. We do still do some face-to-face conversations because obviously if someone is very hard of hearing or has a learning disability, it can be really challenging over the phone. So what we try to do is focus on what does that person need, and we'll do it in whatever. We would even do a Teams meeting if they needed us to.
Tony.
Yeah, thank you, and thank you very much for that really excellent presentation. I just wanted to highlight that this week, Health Watch, with support and in collaboration with Caring for Carers, plus Torbay Carers and Devon Carers, have launched a survey around unpaid caring, particularly focusing on well-being of the carer and isolation. It's a two-part process, so it's a general survey, but there's an opportunity for carers to sign up for a guided conversation over the phone onto some of the issues that they raise, and so we can dig into more depth around that. I think the beauty of this is we've been able to take in some of the stuff that the Caring for Carers team wanted to ask, and likewise for Devon and Torbay, and wrap it into quite a comprehensive survey. It's due to run for 6 weeks with obviously the guided conversations going on as long as they need. It's been publicised through our networks, through the caring organisations and their networks, and there's an opportunity to do it either digitally or as a paper copy. So hopefully we've covered some of those bases with that, and I guess at some stage the report will be ready for further discussion.
Emma, I'm sure you know what I'm now going to say to you. can we make sure that that's on the council's website? Get the details from Tony. That would be brilliant. Thank you. See, she's got a notebook out already. She knew what I was going to say. Thanks. Jemima.
Yes, two things. One, I should have said when I first spoke. I wondered whether the census information tallied with what you knew about how many carers and the kind of people and that kind of thing, or whether it's highlighted some kind of unmet need that you didn't know about. And secondly, around young carers, we've got a big attendance campaign at the moment. And I just wondered if we had any data or understanding of how being a young carer is, does it impact on attendance at school? Thanks.
Thank you. I mean, many years ago, and John probably remembers this, we did a Who Cares for the Carer a scrutiny. And young carers are one of those things because at that time schools didn't record that Junior Miggins was a carer. They might have noticed that they were coming in late, but nobody actually, not a lot of schools recorded that. And I think we did make some progress. And I think that is, from what we're seeing in this report, that is getting much better. But yes, I think you're right with the census. It would be interesting to find out how those facts that came out for Plymouth for the census correlate to what we know. And I think you will probably find there's a big gap. Sort of thinking about my household, I mean, my daughter and her partner, if I'm not well, they're my carers, you know, and certainly with a long-term illness, I don't recognise them as my carers, but let's be honest about it, they are. You know, we live together as a unit because of me and my medical problems, sort of thing. So I think, yes, there are a lot of people that, whether they put themselves down on the census as carers, I don't know. I must ask them. So I think it's interesting to know, and I think a lot of data, as you say, from the census will highlight the fact that we don't know the full story.
I think that's absolutely right. I always have a suspicion, particularly about young carers. I just look at those numbers and think they feel way too low for the other challenges we see for families in the city. So we can go away and have a dig at that census data. In terms of attendance, there is absolutely the attendance campaign at the minute. There's also, which was launched at Cabinet on Monday, the new SEAT strategy, the Seeking Employment and Training Strategy for Children. And I think from memory, young carers are a specific group in there. And recognised for their vulnerabilities around being able to access and engage with education. So we need to keep pushing that agenda because still too often we see children turning up at school late or perhaps not with the right uniform or wanting to keep a mobile phone nearby and being told they can't. And of course that's all rooted in anxiety about the cared for person. So we want to keep pushing that understanding of these children are not being difficult, they are struggling. They're doing a full-time job before they even get to the school gate.
Thank you. I think that's a conversation we need to have with Councillor Creswell as well, in with it, with her hat on about schools. But brilliant. I'm very conscious that we've gone way over time, but I think it's important that we have these discussions. I paid a visit to the Elder Tree and they roped me into carpet curling. And that's quite mind-boggling actually, but it was brilliant. You know, so there was a 95-year-old playing, there's somebody else that had mobility issues, then somebody sat in a chair playing it, and it was great because that camaraderie and that, you know, sort of, that was really great. And I think they all then sat down for a nice little lunch of various healthy things, and so it was good. They'd all had that interaction, and I think that's one of the things that I learned a lot from talking to the Elder Tree as to how many services they did, obviously linking in with improving lives and everything. So I think it shows there's an awful lot of things going on out there that we don't know about until you go and pay a visit like that. I'm going to bring Tony in and then I'll bring you in, Emma, as the final.
It's just to make you aware, Mary, that Michelle's got her hand up on Teams.
I'm glad you can see it because I can't, because I've got David in and Ruth on mine, so I'm missing Michelle. I'm sorry, Michelle. Do you want to come on in?
No, no, that was okay. That's okay. I'll jump up and wave around next time. I hope we're able to do this, but I think it would be useful to share that video or with other organisations such as ourselves and UHP, because I think if we're sharing it on our website, that's showing that we're doing it as a city. It's a city approach, really important to us. And actually, it just highlights what's out there for young carers, older carers. But I don't know. I mean, that would be about permissions from the people in the video.
I'm sure we can get that sorted. I think if they were willing to stand and play rounders on the hoe for a video, they're probably up for anything, quite honestly. So I think, yes, if we can look, let's have a conversation about that and see what we can do. And I think any organisation that's linked in with us, we could see if they would like it to put on their website. So I think that would be great. Emma, do you want to round up?
Yeah, it was just a very final word. You mentioned Elder Tree. They did a wonderful set of barn dances in the Guildhall last week in that searingly hot spell. And I went along, and it's the richness of the conversations. You just stand at the side of the room and you hear people connecting and see that you can literally see the loneliness dropping away from them. So all those groups, all those events, lovely. It's not necessarily about the thing they're doing. It's just you see the human connections forming. So yeah, lovely, lovely work.
Yes, you realise you're not alone, and I think that's the important thing, isn't it? Yeah. Can I say a big thank you, and we appreciate that, and we will sort out what we're going to do. And certainly, Carers' Rights Day, we need to making sure that that's on our websites and everything. Whether we can get anything organised for Monday's council meeting, I don't think. I think we're pushing our luck on there, but there's one in November. So if we need to aim for that one, then so be it. But I think that video is so powerful. I think it's great. Okay, thank you very much, team. Do appreciate that. Ruth, how do you follow that with your report?
Well, I think it's fantastic to see the video, as you say. We know it's such a big issue. We know the massive impact that it has on young carers, how seriously they take their responsibilities, but what the impact that has on them. So just a fantastic video to see. So I hope I'm not going to slightly, lower the mood a little bit by bringing us back to talk about inequality in life expectancy, etc. So I am going to, bear with me 1 second, I'm going to share my screen, hopefully. And hopefully that has worked for you. Let me go into the right mode. Slideshow mode, hopefully. Sorry, it'll take a second. There we go. Hopefully you can see the presentation now. So you'll have seen the Director of Public Health annual report is in the pack in full, and I'm not going to go through all of it. It's also available on the website in case anybody wants to look at that. It's on there. It's on there in full. What I wanted to do is pull out a few points today, and I think there's a couple of things I've tried to judge what people might be interested in talking about. And there's a couple of key things for me that I wanted to pull out. One of which is a bit of an overview of where we are around life expectancy.
Ruth, I don't know if you can still hear us, but you're frozen on us there at the moment. We will get our tech wizards on this. I think it might need it to go out and come back again. Yeah. Yeah. Michelle, are you back again?
Well, I don't think I froze out. It's definitely Ruth. So whether she needs to come out and go back in again.
That's what we're going to get the guys to have a look and see. All right, so thanks. Okay, well, I'm going to call a 5-minute comfort break while we sort this out. All right, so 5 minutes, and hopefully We'll all be back again. All right. See you in a moment.
Is
Councillor,
Elliot
we'll,
there?
we'll get Ruth. You're back with us. Great stuff.
Yes, I'm sorry, I got kicked out. It said I was kicked out, so I don't know what to do about that.
Well, what can we say? No respect.
Ah, we've just had a little Wi-Fi power cut apparently.
Ah, right.
So apologies. I think that's why I got kicked off. I just had a message on my phone to say the Wi-Fi was interrupted. So apologies.
Okay, well, if it happens again, we'll know that you'll be back with us as soon as possible. That's
Yeah.
fine. Okay, floor is yours again.
Right. Thank you. And I will go back to sharing my screen. I hope people know that we're normally quite experienced at doing things via Teams and don't normally have these issues. So apologise for that, and let's hope it all works now. So if I do that, and then I'll go on to slideshow again. That was the point where it seemed to crash last time. So slideshow. So hopefully you can see the slides, and you also hopefully should be able to see me now because I remember to press the right button at the right time. So I was just moving on to say, to emphasise how Plymouth has a citywide plan tackling health inequalities. We know that to try and tackle inequalities in life expectancy, in healthy life expectancy, we have to look at those wide determinants of health. And this is a model that we often use around that, where the individual is at the centre, and all of us have some factors. It might be linked to our genetics or our age that mean that we might be more or less likely to develop some illnesses. But all of those other things in the wider determinants impact on us. So our lifestyles, the communities we live in, the economy, and whether we have a job that gives us a good wage, but is also a good job that keeps us safe and gives us opportunities. The built environment, how much we enjoy living where we live, the activities that we do socially. We just talked about the importance of that social connectedness, and the natural environment that we live in. All of those things are really important. But also, sadly, we also have to reflect that there are some things that are external to Plymouth that we can't control, and that also impact on all of these factors. The obvious one being a global pandemic, the global issues around economic downturn and the current cost of living crisis, of course, we're going to talk about a little bit later, and the impact that has. And also, of course, Plymouth's policies are one thing, but there are also national policies that set many of these, the frameworks for many of the things that we can do within Plymouth. So Plymouth Plan is really important to this, as we all know. So in recent times, we've obviously, we've seen changes in, changes in life expectancy. So on your screen at the moment, this is the life expectancy for males, which is the lower one. So we have to never forget that there is an inequality in life expectancy between men and women, and females, which is the upper one. And in this green area, you can see that life expectancy was continuing to improve on a really pretty steady trajectory, looking pretty good. And then we did start to see a bit of a turnaround. So we started to see it's slowing down. It didn't reverse, but it started to slow down in this blue region. And we were all looking at what was going on and what were the causes of that and what did we need to be concerned about. And then, of course, in the orangey bit there, the global pandemic hit and we saw a drop in life expectancy. And apologies that this is the most up-to-date figures that we have for that 3-year average life expectancy, which is the most robust measure that people use. But we know that we did see that slight drop. And the bit that's probably more worrying about that, as we always talk about, is the way in which that impacts across our population when you look at the most deprived and the least deprived in society. And this curve, again, is this time it's split into deprivation. So it's deciles of deprivation from the least wealthy, the most deprived at this end. And we've said this many times, but people living in more deprived areas have a lower life expectancy. This is across England, I should say. But what happened is when we've seen changes in life expectancy, the changes have been larger. So the grey curve is from 2015, both for females and males, and the blue curve there is 2021, and the black curve for males 2021. And you can see that the changes in life expectancy, they were seen across all deprivation, but they were more accentuated as you got to the most deprived areas of the population. So unfortunately, that effect that we see so often, which is that any impacts like this really do impact most deprived more. That they are probably less resilient for a variety of reasons, mainly to do with those wider determinants of health, to the sorts of changes that we've seen. And it's very well known that infectious disease tends to spread more easily in more deprived populations. And of course, when we recall back to the pandemic, we look at the kinds of workers that were out there on the front line of making sure our bins were collected, making sure we have food to eat, all of those sorts of things, caring for people. Often, many of the workers that are less well paid. So we know that. So that's what's happened so far. That's 2021 figures. So that's through the pandemic. This gets a lot of negative press when this is said, but COVID isn't over. So we are living with it, but it isn't over. And we do still have some ongoing challenges, which are probably not just the pandemic, but a combination of the kinds of factors that we are seeing at the moment. So we're seeing things like there is still a number of people dying from COVID. It's been quite low for the last month, 2 months maybe. So things have been really quite good there, but there are still people that die directly from COVID. But we also know that COVID can increase risk factors for a range of other illnesses, in particular things that impact the heart and the circulatory system, so a whole range. But we also know that there are probably other things impacting those as well. So we're worried about the cost of living crisis. We're worried about whether people didn't receive care during the pandemic that was preventative, that kind of early preventative care, and now could be leading to seeing more heart problems, circulatory problems. And we're also concerned at the pressure that the NHS is under, obviously, and whether that's having an impact as well. We do see data regularly on this, and this is nationally available data. This is online, so I'm only sharing something that's easy to see. I have got slightly more up to date data since then. And this is really helpful because it basically shows the light on this upper curve. The light green are where more people have died than you would have expected based on the 5-year average pre-pandemic. So it tries to take out the pandemic effect. You can see that at the beginning of the pandemic, we had these two large peaks in deaths. And you can see that in between, there was a little bit of a lower death rate than you might expect. So a little bit of compensation, but not compensating anywhere near that whole peak, of course, so leading to an excess deaths. And as the pandemic's gone on, the peaks have got fewer, but we are still seeing excess deaths. And you can see this for the last, this data would be almost 12 months of data, where very, very rare for us to have fewer deaths than you might expect to see. On this lower curve, this shows all of the deaths coloured by whether it is the sort of yellowy colour is direct COVID deaths and the grey are other deaths. So you can see that that correlates with these big peaks here. But you can see that although there are some deaths, it's not due to COVID. It's not explaining in full the excess that we're still seeing. I think so far this year, since January, we are still seeing an excess, which is overall about 6% more deaths than we might expect. But that has been low for the last couple of months. So we have had what you might call a reasonable summer. We haven't suddenly been massively below the expected rate, but we have at least not been seeing excess death at the moment. But obviously, we know that COVID is on the rise again. So anyway, that's the kind of thing we're looking at routinely and regularly to see what's happening. But just going back to looking at life expectancy. So we talk about life expectancy because it's a very easy thing to measure, because it's so absolute. But it's very clear, it's very easy to measure. But we do have to remember that somebody's life expectancy has probably been influenced by things over the previous decades. So it's quite a slow measure to respond to things that we are doing. There are some things around public health that have a more rapid impact, but some things also can take a long time. So if you're looking at work around the wider determinants, that can take a very long time to show up. But obviously, if you're doing things like smoking cessation, you can start to see the benefits of that within months, really. So there are sort of some quite difficult time lags What we're seeing in Plymouth is that actually during the pandemic, as you probably know, we were tended to be have slightly lower death rates than many other areas. We were within the few lowest local authorities in terms of death rates most of the time. And what we're seeing in terms of our life expectancy compared to England is that we are still below the England value, but we are, when you compare us to other local authorities that have similar population, similar deprivation, etc., we're actually comparing very well. So compared to similar areas, we do have our life expectancy for both males and females is at the top of that table. There's a little bit of there's always uncertainty over the measures and things can change a little bit. So I'm not saying we'll always be number one or anything like that, but we are looking relatively okay when you compare us to that sort of comparable local authority areas. I'd always like to be chasing England's, and we'd love to be longer than England, but we are not looking too bad there. And we have narrowed the gap between us and England a little bit for males, but not for females at this point. If we look at the inequality in life expectancy, so this is obviously a really key one for us. Both of these charts, so this left one is for females, the right one is for males. The black line is England, and the different years. So 2010 to 12, the average of those 3 years, up to the most recent that has been published, which is still not as recent as we'd like, 2018 to 2020 average. And the black is England, and this paler line below for this one is the inequality for females. And you're comparing the life expectancy for most deprived groups with that of least deprived groups. And what you can see here is a really good thing that for females, our inequality is actually below the inequality in England. So Plymouth is a more equal city for women's life expectancy. So that is a positive. That is one of the parameters that we seek to improve. So that's good. And sorry, I skipped too far forward then, too quickly. But you can see that for men's, we're also slightly below England, but we are a little bit closer to England. These little bars here show us how much we can be really confident that we're different. So the females, we've got a gap there between England and us, whereas for males, it kind of overlaps. So we're on the right side of it, but we're probably not 100% certain that our inequality is lower. It's about the same. So that's, again, positive. And also, if we then compare us to those areas that we said were equal, similar kind of demographics, similar populations, again, we have the lowest inequality. Our inequality gap is actually small compared to those. So again, another positive. So it's always really good to appreciate those positives. I'm going to talk about healthy life expectancy just a little bit. This is another one of those things that we like to look at. And this looks at the life. So there's two factors that we're interested in. We're interested in these 2 points. One point is, when do you stop being well? When do you stop feeling well on average in a population? And then, of course, the second thing that we've just talked about is, and how long might you actually live? And what we know in more deprived populations is not only do they die at an earlier age, but they spend longer of that shorter life in poor health. So it's an important figure for us to look at. And what we see here is that healthy life expectancy for both men and women used to be has been historically a little bit below that for England. So it is below that for England, probably linked to our deprivation. What we've seen in recent years is that for males, our healthy life expectancy has improved. And on the right-hand chart there, you can see that our healthy life expectancy for men is now the same as for England, which is really good. But for female, it hasn't budged. And not only is it not budged, but when you compare it to similar local authorities, it's at the bottom of the table. It's really not good. So one of the things I want us to focus in on over the next year is this sort of twin story of what's gone right with male healthy life expectancy and what's not going right with females. So hence why we talked about the fact that we need to look at that. We've started doing some work on that, and there's probably, I'm going to say 3 themes, but they're quite broad themes, and we'll probably look at more than just that. But roughly speaking, there's 3 themes. One of them is around health. So is this something to do with the way in which women are perhaps accessing treatments? There's a lot of work that's gone on nationally around a women's health strategy, and so there will be some work that's being done at the moment looking at access to treatments and health advice for those health conditions that are specific to women. But it's also broader than that, isn't it? So we want to make sure, are the gaps in services that women might be accessing compared to men, and that also includes risk factors. So, are women not identifying some of those earlier risk factors and then being treated for them? So we're doing work around that. There's nothing really obvious that looks different to our comparators at the moment, but we're looking at that. Another strand is around the economy and jobs. And we're particularly interested in that because obviously that's a key factor that influences life expectancy and the way you live your life. But also because we do know that there's some things that are a bit different in Plymouth to some of those other comparator areas. So we do have, in particular, we do have low paid work for a lot of women. The average doesn't look too bad, but we do know it kind of splits into two groups there with there are some really good jobs for women in the city, but there are also a lot of the jobs that are quite low paid. And also women are reporting that at those lower paid jobs in particular, they can't do as many hours as they'd like to do because of limits of childcare. So not being able to access childcare, not being able to access affordable childcare. There's a whole stream and a whole area of topics there that we want to really look at around that. And the third stream of sort of focal point, which again is a very broad stream, is around the lived experience. So we've got a number of factors there that we're interested in looking into. One, of course, is linking with violence against women and girls and what that might be meaning for people. We want to look at, carers was one theme that was just discussed there. We know that generally speaking, women do bear the burden for caring. So is there something there that we need to be looking at a little bit more? And of course, these work streams, they do interlink. So are there impacts of caring and work, for example, that we need to look at for women? And there may be other factors as well that we'll be looking at in that link to, where we are, the fact that we're a coastal city. There are a number of parameters that seem to link to that. Coastal cities generally, or coastal areas generally, have slightly poorer outcomes, for many outcomes than you'd expect with their deprivation. So, but we need to understand more about that. And the reason we need to really understand more is so that we know what more we should be doing, so to target those interventions. So that's one of our particular themes that we're looking into. So I just wanted to talk a little bit about Thrive Plymouth. Thrive Plymouth was launched in 2015, as you all know, as our 10-year programme for tackling health inequalities through looking at lifestyles. There was a real recognition that not smoking, that drinking in moderation only, that eating healthily and that moving more can all impact our health in positive ways. Our actual statistics on these factors are really not too bad now. So our statistics on our risk factors are not bad at all. Doesn't mean there isn't a lot of room for improvements, but of course it can take some time for those positive risk factors to really show through when we're looking at life expectancy and healthy life expectancy. We had an annual focus around Thrive Plymouth, and we used that to widen the number of partners that was working with us. All sorts of fantastic things came out of Thrive Plymouth, and we've done a huge amount of work with a huge amount of partners through our system design group. Some of the work around wellbeing hubs, of course, has been part of this. And one of the things was a really clear evolution of Thrive Plymouth compared to when we first started. So when we first started it, for those that might recall, we started it with a quite epidemiological view, and then we broadened it out. So actually, let's look at the positives rather than talking about deaths and dying and illnesses. Let's talk about the positives. What do we want people to do more of? And I think since Thrive was then launched in that way, we've moved away a little bit from talking about choices with those behaviours and recognising that actually there's a huge context behind that choice. And sometimes it sounds, to use the word choice, it gives a negative impression if people are making what we might call unhealthy choices, because we need to recognise that people don't often have freedom of choice often. And when a lot of the work that we've done around things like appreciative inquiry has really highlighted that actually often people are making really sensible choices. It's just that their choices are based on what's right for them and their families today and tomorrow and next week, rather than that sort of longer term thinking that's what we need for healthy lifestyles. We've really recognised mental health and well-being and how important that is in being resilient to, well, it's very important in its own right, but it's also really important in regards to being resilient to some of these behaviours. Nobody really makes a fantastic job of changing one of their lifestyle behaviours if they're not, if they don't feel strong enough and resilient enough to do it. And likewise, we all have things that happen in our lives that we need to be resilient to, and sometimes some of those can knock people back an awfully long way. So how do we support people in, first of all, starting with their well-being and then starting to look at other things that they can do? We've also become trauma informed as a city, so that wasn't a thing when we first started Thrive Plymouth, that sort of movement around understanding the impact of particularly adverse childhood experiences hadn't really been established, and it now is. And we've also done a huge amount, as you know, around appreciative inquiry to really understand what do people need, how do we work with them. The work of the Alliance on how different organisations come together to support people has also changed the way we think about Thrive Plymouth. And so we are now about to start what would be the 10th year of Thrive Plymouth. And so during this next year, we are going to be coming to Cabinet in springtime with a new plan. We don't think that the 10-year programme of Thrive Plymouth should end, but we will be talking to partners to get their views on that too. So the question there is going to be, what do we want to do with Thrive Plymouth the next 10 years? And how do we want to frame that? And what do we want to do? So we'll be doing some work on that in the next 6 months and talking to all of you to get your input into that as well. So finally, yes, this is my final slide. So just to sum up, life expectancy in Plymouth is lower than England, but it does compare well across similar areas. Inequality levels are lower than England for females and about the same for males. We do have more work to do on female healthy life expectancy in order to see the same improvements that we have seen in males. And then I will be really looking forward to more of a conversation with you all around Thrive Plymouth over the next 6 months so that we can go to Cabinet with a plan that our partners are happy to support. So thank you. That's I think that's it from me, and I will just get the computer to work so that I can stop sharing.
Thank
Lovely.
you. Thank you, Ruth, for that. Always a fascinating report to hear about the health and well-being of our city, and I think that it is important that we look forward to the next 10 years of Thrive. So I think we'll all be looking forward to those conversations, because obviously priorities will have changed in that time, and I think it's essential that this is very much a moving object and suits now. So that's great. So any questions for Ruth? Jemima?
Thank you, Ruth. Going back to the excess deaths bit, I wondered what evidence there is, or what your feelings are around what is contributing to that. Is it the much rehearsed things that we've talked about, difficulty getting a GP appointment, waiting in an ambulance outside A&E, waiting for an ambulance to even get to you in the first place? Is people kind of leaving it longer when they've got certain symptoms, so then they're presenting in a more serious condition, or more people dying at home than, all those factors?
It's really difficult, isn't it? It's really difficult to give you clear answers. What I can say, so there's a few things I can say. First of all, the actual causes of the death that we're seeing in excess are mainly to do with heart and circulatory systems, and there are acute respiratory as well, which would link with direct COVID. One positive thing I can say is that cancers are not being seen in excess at the moment, so there's no clear evidence that there's anything at this level. I mean, clearly there are people doing much more detailed analysis and looking at it in great detail, but it does look as if there's no excess deaths around cancers. So that's really positive, and does kind of suggest that the healthcare, however difficult it is in the NHS at the moment, those kind of urgent cancers are being identified and dealt with, at least at that population level. So I honestly, I don't want that to sound as if I'm taking away anyone's experience, because I'm sure there will be some people that are struggling. But at that kind of macro level, we're not seeing a big issue around that. I think that there is clear evidence that COVID can cause these sort of microclots, which can have an increased risk of hearts and circulatory issues. And I believe that risk's thought to last for sort of 6 months to a year, the elevated risk after a COVID infection. So the issue with COVID in particular is that we don't know what's happening until quite a long time after it's happened, because it's a new disease. And all of the studies obviously are looking at what's happened in the past. So anything that's coming out tends to be quite, it's even the research that's being done at the moment is tending to be done on people that had, one dose of COVID back, a year or two ago. And so we were in one of the earlier waves. So we don't know a lot about some of those impacts. Again, there's also then evidence, and it's common sense, but there is also evidence that delays in getting into hospital for certain acute conditions can lead to an increased death rate. So we know that that's happening, or we know that the logic says that that is happening. That's what the research suggests. And certainly when the NHS is under huge pressure, which it has been for various points of the year, that is a big concern. And yes, again, another issue, of course, is that worry that people will be putting off going to the GP for those little niggly things that they think perhaps aren't anything they'll worry about, or perhaps they're not getting those slightly incidental checks that they might have had because they were popping into the GP, and so they're therefore getting their blood pressure checked, etc. There are programs in place to try to pick up on some of that, know your numbers checks, and we are our PCNs across the city have been doing some work on hypertension, checking for diagnosed for cases where they've had one off reading, and trying to promote people being aware of blood pressure. But that is a worry as well. But the literature at the moment doesn't really give us anything that we can say, well, X proportion because of that factor and Y proportion because of that factor. So I think that the experts are all relatively confident in saying what I've said, that it's that combination of factors, but nobody is publishing anyway anything that lets me kind of put that into context. What I will say just about Plymouth is that in the last year, since the 1st of January, which was what I've been looking at in particular, we have had fewer excess deaths in Plymouth than the England average. So the England overall has been about a 6% excess, and in Plymouth we've had about a 4% excess. And many other areas in the southwest have had higher death rates than we have. But as I say, unfortunately, I'd love to be able to identify why. That's good, but I can't tell you exactly what's going on. But I know Michelle's got her hand up just in case, Mary. I'm not sure if you can see.
Can I just say, can we be succinct? Because we are very, very far behind on our agenda this morning. So, Michelle, do you want to come in and then I'll bring Jemima back?
Yeah, just quickly, I think it actually strengthens the argument around our work around prevention and that continued work. And I just wanted to make a statement, really. One of the big focuses that we have is around physical health in mental health. So that is key, and the percentage of people with a mental health issue dying younger. So that's the focus of Live Well Southwest.
Thank you, Michelle. Jemima.
Yeah, it was a quick thing about what Ruth said about COVID and the 6 months after having it. It's just doesn't feel like there's a strong message at the moment about actually it's a really good idea to avoid getting COVID even now. I know there's a message around living with it and all those kind of things, but actually if we're saying that there's, for the 6 months having an infection, certain risks are raised, then there is just a message around, still doing everything you can to avoid getting it.
And certainly the winter plan that's coming to scrutiny at the end of the month will definitely be hearing about that and about encouraging people to get more, COVID jab, flu jabs and whatever. So I think this is something that we need to keep pushing. We can't relax on it. And certainly it's all very well saying 6 months, whereas in fact, I'm sure all of us know of people that still have long COVID after having COVID a good 18 months ago. It's still affecting their lives. So I think, yes, it's something that won't leave the health agenda, whatever. I'm going to close now, but there's a recommendation here that we note the content of the report and in particular the concerning aspects of the cost of living crisis on health and wellbeing, which will be echoed in the next two presentations really, and requiring the GPH to return to Cabinet in the spring with a proposal for the future of Thrive. And I would say, having listened to Ruth, that we know that she'll be engaging with a lot of you for that. So are you all quite happy with that, members? Yep, excellent. Okay, and what I didn't say from the last one was we made the recommendation that the Health and Wellbeing Board is asked to note the report from the Carers Action Plan, which I think we did, but we added some extra bits in anyway. Right, okay, now I'm going to propose a change in the order and invite Councillor Dan to bring her cost of living. Now let's get the title right. The cost of living, tackling the cost of living in Plymouth report to us, and then we'll go back to Tony for his. Sue, obviously you're very much aware we're way out of time. So if you can do the essentials, I'd be really grateful. Thank you.
So you're asking me to be succinct? I'm not sure about that. So if I just give a quick introduction, then I'll ask Ruth and Rachel to actually go through the plan, and then I'll just finish off with letting you know what next steps are between now and Christmas. So when we took control in May, one of the things we were very, very much aware of is that a lot of people across the city are living in different times. With rising food costs, rising energy costs, rising health costs, there was a need to address and offer up some help and support for people who may be entering into crisis or presenting in crisis, or actually just having problems managing their budget. And we're acutely aware that the cost of living crisis is hitting families and households that perhaps in the past have not had to seek help or support. But they are now. So we launched the action plan back in the middle of August. We hadn't sat still all summer. We'd made sure that we'd used as many communication channels as possible to let families and residents know what was happening during the summer that was free. And it was a very, very, very popular hit on our website. We have completely revamped the website and made it a cost of living hub, because the plan isn't just about what the City Council does, it's actually about much wider, it's about what the city can do as a whole. So many partners across the city and stakeholders who are supporting vulnerable people either with mental health issues, with food, with directing people towards energy costs or housing problems. So all their offer is also available on the website. So it's becoming like a one-stop shop for cost of living support. Ultimately, this is going to move into a wider plan about how the city will draw up an ongoing support mechanism to tackle poverty across the city. We've got the Child Poverty Action Group, so this goes beyond that, and it's much wider than all the things that was happening with the council last year. I think the thing that has been a real joy to see, I think, is that we had a workshop back in the end of July, just inviting people from across the city who were interested in or had something to offer, and how many different people turned up at the workshop. When I say it wasn't the normal suspects, I don't mean that in a derogatory way, but I mean we had banks turning up offering help and support, and we're going to try and get the banks together to work with Citizens Advice Bureau, for instance, because the banks are concerned, because normally if people are going into financial crisis they don't tend to turn to the bank first, and actually the banks want them to go early so that they can offer help and support at an earlier time. We also have had help from the Plymouth Charter, so they work with over 300 businesses, they contact nearly 700 businesses on LinkedIn, and they're working with employers about what employers can do as well to offer support to their employees. And this is why I'm saying the cost of living plan, it goes much wider than what we do in the council. So if I hand over to Ruth and Rachel, and if they'd just like to tell you how the plan developed and what sort of the pillars are and the areas that we're looking at, and then perhaps at the end I'll come back and just do a little bit about future communications, because obviously this is a dynamic plan and it is constantly changing. Thank you.
I'm going to go straight to Rachel, if I may, because she's she's very familiar with all the details of the plan. Thank you.
Okay, yes, thanks, Councillor Dan and Ruth. So as Sue's already said, we had a kind of plan in place, but it has definitely developed much more since May, and we had that workshop which had over 80 people attending and over 70 organisations, and really helped to kind of bring the plan on and develop it. And we had lots more offers at that workshop, which we've added into the plan, and the plan was launched on August 23rd. So as Councillor Dan has already said, we've got the cost of living hub online, but the plan has now has developed into 4 themes. So the themes are offers and discounts, and we've already I wanted to give an example under each of the themes really, but Sue has already talked about the leisure offer. So over the summer we already before the plan was even launched, we already had the free things to do over the summer part of the plan was launched already, and we had the Plymouth Active Leisure summer programme, and we had the family swim, which was actually for £1, so very cheap, and nearly 11,000 people attended that family swim for £1. So that was really excellent outcome. So we had so the theme around offers and discounts is we've got lots of things in there, and we're going to be also doing a similar thing over the next few kind of school holiday periods. So for example, we're already collating information on what's going to be available at Christmas, so we will have lots of information around support that people can get at Christmas, in terms of connecting with other people, but also food and that kind of thing. So we will highlight that. And then the next theme is making the money go further, and Sue's already talked about the offer that employers are making. So our economic development department have been sending out lots of information to employers, and there will be an employers summit a business summit coming shortly, which will help to cement some of those kind of joined up offers as well. But we are doing as well a promotion on, basically a benefit take up piece of work at the moment. So in the next week, and also going into the Chronicle for the next 4 editions, there will be a check your benefit entitlement page, which will promote people connecting to the benefit calculator on the Citizens Advice website, and we'll make sure that people are checking their benefits, and we'll make sure that gets promoted really widely across all of our partners and the DWP, etc., so that people are checking their benefits. The third theme is crisis support, and there's lots of work that's been going on around that. We already have a lot of things in place. People, as we've mentioned, the Household Support Fund, people are probably aware that the Household Support Fund has been supporting people with energy and food, and Lee mentioned earlier that we funded some of that for carers as well. So there's lots of support for people who need it in terms of buying, if they get into a crisis with their energy, helping to pay some of their debts or getting them some new white goods. And we're doing a lot of work around the food system in the city, and making sure that there's a much more organised system around people getting help with emergency food, but then moving on to other food support. So we're doing a lot of work around setting up new food clubs and food co-ops to try and move away from kind of the emergency food banks that we've got at the moment. So that's developing in that area on crisis support. And then the final area is asks of government. So that's really we've kind of asked our partners to give us you know, any kind of areas that where they have difficulty with current policies, and things that we might want to put a bit of challenge in terms of that. And you'll see in the paper there's some really good proposals actually for things like can we create a green trades business centre in Plymouth, and can we have some flexibility around adult education and skills budgets. So that's the fourth theme. So in order to be brief, I just thought I'd highlight a few examples from each section, and I think that's it really. Thanks.
Thank you, Ruth and Rachel, about that. Sue, did you want to come back?
Yeah, so a lot of this is about how we communicate it and how we signpost it for people to access it, because that is the key thing about this plan. It's not it's not a money plan where we've got loads of money to give away because the city hasn't. So we've distributed these. So we've done thousands of these already. They're in the Wellbeing hubs, libraries, 60 churches, got them in the job to PEC advisors, and actually we're going to order some more and just make sure that just people can just take them. So when, like Jemima asked me for some, she said, so when you're going to residence meetings or when you're meeting people, that we can take these out and signpost. And on the back, there's some really simple explanations as to what you can find actually on the hub: financial help, energy, food, help for families, housing costs, employment and skills, mental health, and warm welcoming spaces. And that's what the actual plan looks like when it's printed off. But of course, because it's dynamic, I'm sorry I can't share this, but what we've done is we've tried to think about the themes between now and Christmas and how we can promote different elements of the plan, because we haven't got one audience. We've got families, we've got people who live on their own, we've got people who are working, we've got people on low income, we've got people who are struggling with their housing costs. And what we've done is we've tried to do some themes that between now and Christmas, every couple of weeks, there'll be different things coming out. And it's not always going to be the council, it's also going to be working with our partners. So I just thought I'd read out the sort of the headline things. There's schools and free school meals, getting what you're entitled to, which is what we're doing now, and the best start in life, talking about maternity allowance, sure start, healthy start. And then we're doing a little bit dealing with debt. And I think this is why it's a dynamic plan, because one of the things we found out from some of the feedback is that actually there are some people who may have a gambling problem within that debt. So we're actually bringing in new themes as it becomes highlighted, that it becomes an issue with people. Food on a budget, mental health support, housing costs. We've also put finding work as well, because if we can encourage people to go to work and perhaps increase their hours, it helps with their costs. But it's also linking up with this, what Rachel was talking about, how we can try and upskill people so that they're able to earn more at work. Fund for free in half term. I will say here that we've managed to get a one-off funding for our free bonfire again this year, because that had been withdrawn under the last administration. But actually, come November, it comes at the end of half term. To have the free bonfire, it is something that people enjoy. So we have the Plymouth Waterfront Partnership and our wonderful economic development team for that. And of course, and this is what happened last year. So coming to the wards at the end of October, we can start doing a campaign about keeping warm again and having warm spaces. We're going to talk about planning for Christmas. Christmas is always a really, really difficult time, especially if you've got families with children. So we've sort of called it planning for Christmas, but without feeling like a Scrooge. So what you can do to plan for Christmas in terms of food and Christmas presents, so that you don't necessarily increase your level of debt. And I think that's probably about it in terms of comms. And I just want to give you one thing. So in August, 2,000 people accessed the online cost of the living hub. So that's just in August. But the social media posts over the summer have been seen 200,000 times. And they've received, and this is what I like, 7,000 engagements. So that's either likes, comments or shares. And I think that's really important. And we've just distributed to our partners a media toolkit so that our partners can start sharing some of their things they're doing as well. So we get a little bit of momentum. And I think that's me done.
Thank you. Michelle, you wanted to come in.
Yeah, I just wanted to make sure. I was invited to a meeting last week with a group of providers, charities, and a very small group. but really thinking about the same thing. And we've made sure we've got in touch with Rachel, because there's a danger of different groups of people going off doing something very similar, where it's far better if we're working together. Um, but hopefully we can join that up. And I just wanted to, this is so exciting and so needed for the city. And I would hate to think there were small groups doing something slightly different.
And actually, I don't think that matters. I think the important thing is that if we can make sure that if people are doing anything to support a community or have something they can offer a community, if they can just let us know, then we can put their link onto the cost of living action hub, and so that people can see it. So it's not about ownership or exclusivity. It's just we're trying to do it as a focal point where we can put as much support on there as we can.
I think certainly between the wellbeing hubs and community builders and all of those, it's how we get it out there. And I'm sure Tony's report in a minute will link into all of this. So I think this is where it's really important that we work as a city to support our residents. You know, that's our heart, basically, that we need to be making sure that we keep everybody sort of involved as much as possible. Yeah, exactly, and that's why we've got that heart on the thing. I've got to say that I sat on the task group dealing with this, and Sue has been so enthusiastic. I think there are times when we could have strangled her a couple of times because she was sort of getting carried away with what she was going to do, but everything we can possibly do to help our residents. There's got to be no stone unturned, basically, isn't there, for this? So a big thank you to Sue and the team that's worked tirelessly with Rachel and with Ruth and us on the task group, that it's really shown what we can do. And I think as Sue was saying, it's a dynamic report, and we're always very happy to add people and sort of organisations to that list to work with, and any offers that anybody's got out there that's going to help things, it's got to be really welcome. So thank you very much indeed for coming along, Sue, and to Rachel, and as I say, to Ruth for that piece of the agreement. And I've got to say to you, can I make the recommendation that the Health and Wellbeing Board note the cost of living plan? But I think we need to add on to that, and everybody carries on working together to improve matters. Thanks very much, Sue, for that. Okay, thanks, Rachel. I think Ruth's got to stay on, but I think you might be released. Thank you. Okay, Tony, thank you very much for agreeing to let us swap that thing around. But we now move over to you for your report. And I know that with the paperwork we've got, some is background reading and whatever, so I'll leave it to you to present what you need to do. Thank you.
Thank you very much. In the board packs are the three full reports, two from Healthwatch England and one from Healthwatch in Devon, Plymouth and Torbay, around cost of living. I'm going to attempt to summarise that now very quickly. Essentially, we, as in Healthwatch England, at the start of the cost of living crisis, when things were becoming apparent, started to track over 2,000 people through a 4-month period, and seeing how they managed to get on. And they produced two reports, one in the January of this year and the second one in May, with the findings of that. And their focus was really on the impact of the cost of living crisis on people's health and well-being, and the rising cost of things and how that affected them. To summarise from their reports, what they found was that people who were disabled or on means test benefits, and particularly in the age group of 18 to 24, more likely to avoid vital health services due to fears of extra costs. And the slide here kind of summarises that. And they looked at things like prescriptions, over-the-counter medication, transport to appointments, associated costs with appointments, which could have been because of a digital access, so internet costs, etc. And equally, if they could get a dentist, actually going to the dentist. We're aware that dental in particular is quite a significant problem. They also found that people were increasingly avoiding vital health and care services, and it highlights that, you know, whilst we say the NHS is free at the point of access, there are certain services within the NHS that you do have to contribute a payment to, and I think it's been well rehearsed before about the issues around dental access and the cost of treatment there. But I think some of the stuff that has come up has been around access, and some of that is because it's the way you were able to access services. So GP access has been focused quite heavily on digital or using the phone number. If you don't have free calls on your phone, waiting in the queue for over an hour becomes an associated cost on your phone bill. And at the end of the day, you know, people are just trying to get help and access services around that. The cost of over-the-counter medication has obviously gone up, and we obviously see an annual increase in the cost of NHS prescriptions, all of which are adding to the pressure on people. Based on that, Healthwatch England recommended to the Department of Health and Social Care that primary care teams make people who need medication aware of prepayment options. Dentistry teams offer checkups based on individual need to free up more NHS slot, and I think that's really talking about private dentistry. And more people are made aware of the healthcare travel cost scheme. However, I'd just like to point out the quote at the bottom of that slide about support for somebody who had been diagnosed with leukemia, had a cost associated with the treatment, and was on benefits, and basically when she applied, she got £4.60 back for quite a few journeys that she made, and obviously that didn't cover her costs to attend those appointments. Healthwatch England also found that half of their respondents had avoided going to the dentist because of the cost of checkups, with almost a quarter of that said they are anticipating doing this in the future. A third of respondents have cut down or stopped support from services that they pay for privately, such as physio, earwax removal or counselling. Half of respondents said that changes they have made because of the cost of living have negatively impacted on their ability to manage an existing long-term condition. And almost 3/4 said the changes they have made due to the cost of living have negatively impacted, particularly on their levels of stress and anxiety. Following on from the work that Healthwatch England did, Healthwatch in Devon, Plymouth and Torquay ran a local survey through March to May, asking very similar sort of questions to Healthwatch England, just to see, you know, if the local impact was the same as the national. And that involved, go back one. That involved kind of asking what the effect had been up to now, and what the individual thought the effect was going forward. And from the commentary there, there's no real difference in the findings that we found in the county to what the national findings have. So I guess in summary, there is a health determinant factor within the cost of living crisis, where people are avoiding because of cost of one factor or another, actually attending appointments, managing long-term conditions, and seeking support.
Well, thank you, Tony. I mean, that's some amazing facts, and I think with what Sue has presented to us, and I think we need to make sure that we integrate this as well into Sue's knowledge, so that when we look at that again, the task force is still meeting for that. So I think we need to make sure that that's slotted in. So Elliot, I think we need to make sure that the members on that get a copy of this report. I think that's essential. Anecdotally, I've always read in anything to do with people with disabilities that they are adversely affected, whether it's extra energy costs and whatever. But I've got to say, I hadn't put two and two together to think about how some people would find just going to the GP a problem and phoning. I suppose because I'm somebody that the package we have at home have free calls, whereas more and more people are using their mobile phones and don't have unlimited phone calls on there. So that's something I think we need to follow through on that a little bit more, and have a conversation with the ICB and also the primary care networks. Chris, I think that's something that you could perhaps take back for us. I don't know if it's something that you had picked up on that, or whether, like me, the pennies just dropped with you with on that.
Thanks, Chair. Yes, similarly, I think there's a real potential gap, isn't it, for some of those individuals. I will take that back and have some conversations with our primary care team about that.
Thank you. Anybody else got any questions? I think it's essential, isn't it, that we keep the momentum up on this, that we keep sort of making sure that we're linking together more. Rob, with your sort of wellbeing hub side of things, are you picking things like this up on that?
It completely correlates with the anecdotal feedback and some of the quantitative data that we're getting through. It's all these interrelated factors that we've just been talking about, and the complexity of needs when people are getting in touch, and we're trying to build a response to that, and we're speaking with commissioners about some embryonic projects that we've got in place that might support people much more holistically around all of these connected issues. But the costs in accessing, it just feels we're on that long-term trajectory in terms of more of our healthcare by default ending up being paid for, and we're going to be excluding key parts of society along that journey. So yeah, it completely resonates with feedback we're getting back.
Thank you. Jemima.
Two quick things. I think because we're talking about the cost of living and we talk about it all the time and it becomes a phrase we just use that just trips off our tongue, I think sometimes it's helpful to just actually say what we're talking about is the cost of living, the cost of being alive, and the cost of just doing the things that keep you alive as a human being, quite apart from anything, you know, luxury and enjoyable that you'd want to do. Stuff around prescriptions and things I think is really worrying. I didn't know if there's any way of finding out if people are prescribed things but they're not then collected from the chemist, or is there any way of finding that out?
I think that's come out in your survey, hasn't it, that people gauge if they have, let's say they have 4 items and they are paying for their prescriptions, you know, they are gauging and saying, well, what's the most important, and perhaps only taking the one, because, you know, and this is why the prepayment cards are worth taking out and whatever. But again, you've got to have the money to be able to pay for the payment card. So I think that there are problems. So I think we need to think about how, and again, Chris will be essential in taking that back as something. And I'm sure I know David was on the call earlier, but I'm sure David and the PCNs must be taking this into consideration when GPs are prescribing. David, did you want to come in on that?
Yeah, no, thank you. I mean, it's certainly really insightful, and you know, Yeah, I guess so. There are checks. There are various checks and balances in place in terms of certain timeframes for medication reviews, where increasingly we have pharmacists working within general practice teams and pharmacy technicians, and their roles are around very much supporting the practicalities, both in terms of quantity of medication, how medications are delivered. There's a range of people who are getting that delivered at home. So I think there are various checks and balances, but there are people clearly who have a number of long-term conditions who don't pay for their prescriptions, but then that doesn't cover everybody, and so um, uh, yeah, I mean, I suppose I don't really have. I mean, I guess I'm just in the space of uh, reflection, really, on hearing what I'm hearing, and I think it's something that Chris and myself need to go away, reflect upon, and liaise with our primary care colleagues in that space. But there are checks and balances in place. Does that mean that things can slip through the cracks? Yes, of course they do. And I think some of these stories really highlight very powerfully some of those things that we just need to go away and reflect upon. So it's more reflection than an answer, I'm afraid. But yeah, something that we can certainly take away.
No, that's fine. Reflection is good, and I think obviously we can, Tony. I'm sure we can share with David your presentations today and your findings. And I suppose it's that sort of hope that at least GPs or somebody will be saying to Mr. McGinns or Mrs. McGinns, well, we gave you four medications last time. Did you use them all? And getting some honesty from our patients, isn't it, as well? Because what's the point in you prescribing them if they ain't going to be using them? I mean, there's that bit, So I think this is where that joined upness helps. So Tony, thank you very much indeed for bringing this, and thank you to your team of volunteers for pulling all this information together, and certainly as your surveys and whatever go, it's important that we hear them and share them. So thank you for that. We'll make sure, David. I mean, you've probably got the stuff with the paperwork anyway, didn't you? But I think it is essential that we do share it. Thanks very much indeed for that. Okay, now we're going to have another juggle, and you've probably gathered that from the way our topper table has altered slightly. Gary, let me just check. Item, I'll let me have a quick. At item 11, we're bringing forward, because unfortunately Gary has to leave at a certain time, because we've all found everything so interesting this morning. We've been asking more questions and having more sort of queries than let's say we allowed for in the timing. So Gary, the floor is yours. Can you use your microphone, please?
Apologies. Yeah, I thought I'd share a presentation because it will be more accessible than the paper. So, if everybody's ready. So I'm here to talk about the Plymouth Health Determinants Research Collaboration, or Collaborative, which is a 5-year National Institute of Health Research funded project. And the primary partners in the collaboration are the Plymouth City Council, the University of Plymouth, and the Plymouth Octopus Project. For those of you that don't know, any NIHR funding is hard won. They're not easy to succeed at. So it was quite a coup for us to get this research, and for the university. So next slide. So this is a partnership, as I've said, between the Plymouth City Council, the University of Plymouth, and the community, as facilitated by the Plymouth Octopus Project. We received a grant of just under £5 million for 5 years. It's actually 4.7 million. And along with the rest of the country that were awarded this bid, we started in last October. And it's essentially about building capacity within councils and within the wider city outside the university to encourage a research-based environment for the council. It's not a kind of grant-making scheme. It's really about increasing the appetite for research in the council, the use of research in the council, the understanding of research in the council and across the wider cities. In the first round, there were 10 areas awarded this grant, with another 3 that are in a kind of starter year because they weren't quite ready to start, and there'll be at least another 10 this year, so we're kind of in the vanguard. And it's about helping us be more focused in everything we do as a council. So how we commission services, what we commission, how we measure, what we measure, all of those kinds of things. Well, there we go. So the setup, the kind of governance, the boring but important bit is this is what our structure looks like. So Ruth is our overall strategic director. She's a co-primary investigator along with Professor Sheena Asthana from the University of Plymouth. And essentially my role is to lead the researchers in residence and the 7 council staff a year that will be seconded for 40% of their time to the unit. As you can see, we also have lots of access in the bottom left-hand rectangle. We have dedicated researchers for us, and they will be embedded in the council. They're already in the process of making those links and embedding. But we also have access to essentially all of the university. So any issue we encounter, even if it's quite novel, the university will facilitate us having access to relevant academics in the area. So it's a really kind of exciting prospect for us. So just to cover why do we need one, or why did the National Institute of Health Research think that local authorities needed these things? So firstly, it's about evidence. As you know, the NHS is full of researchers. Everything they do is research-based for the obvious reasons. But that's really been slow to roll out to local authorities. So this is about how we become informed around things like best practice. How do we understand the nature of good evidence? So we often in our daily work are presented with reports about this or that, or someone might send us research. But in order to understand the implications of research, you have to understand, is it adequately powered? Is the finding robust? All of those kind of things. But it's also about how we begin to create our own evidence for our unique place and to test our own theories. And quite a lot of that work was already being undertaken in our council before we got the bid. So Dave's work on obesity or Dan's work on vaping have already been informed by this kind of activity. It's also about understanding. So we use appreciative inquiry extensively. We have hundreds and hundreds and hundreds of individual stories across dozens of issues. It's about how understanding why that is helpful in change, why that's helpful in helping people focus on purpose, and why it helps us understand value rather than targets, which often bear no relation to people's lived experience. In terms of innovation, we're also looking at the big challenge for us is not necessarily understanding which technique to reduce blood pressure is most effective. There's a really good, robust system for doing that. But it's understanding why we can't always get that to the people that need it most. What are the kind of organisational barriers? Are there better ways of doing that? Do we need to change our service landscape? We need to understand, are we making inequalities better or worse? So lots of really sensible seeming interventions have the tendency to increase inequality rather than reduce it. And that's because lots of education-based programs are disproportionately taken up by the healthier and wealthier. But also to understand unintended consequences. So quite a lot of what we do, particularly when we do stuff in narrow silos, it's like pushing bubbles in wallpaper, and it's understanding the interconnectedness of all these things so we can take a much more systemic approach to problems. And then it's also questions around the nature of intelligence and data. Do we have the right data? Or more particularly, are we asking the right questions of the data? And are we kind of linking all of our data, qualitative data, quantitative data? So what have we been up to? So although we launched in last October, all of the HDRCs across the country had similar problems. There's quite a lot of preparation work to do in an organisation that's not used to doing research. Really kind of routine processes are not in place, and we're having to develop them. So things like partnership agreements between us and the university and POP and the National Institute of Health Research. Issues around recruiting the team, that's been quite an interesting thing, which I could say a little bit more about later. Sorting out governance. If you're going to do research, particularly if you're going to do research with vulnerable groups, disability groups, children, that kind of thing, vulnerable adults, then you must have a robust, kind of robust system of governance and ethical clearance for that. But it's also about reassuring the National Institute of Health Research we are fit and proper to manage a budget of that size. We're developing a communication plan. One of the early findings we've had going around the council talking to people is people don't have time to read research, so we're looking at alternative ways of dissemination, so maybe short videos, interviews, one-to-one things, going to teams. We're also developing how we're going to evaluate return on investment. Are we spending the money properly? Have we achieved the things we said we would in the bid? We're also aligning existing activities with the new programme. So as I said, some of this work has already been happening, and we need to kind of bring that in-house and subject it to the same rigour as we are going to new things. We are developing the programme of rolling out to the directorates, which I'll say a bit more about in a moment, but we're also exploring options for research and evaluation. And the other thing that's in our bid and that we are actively doing at the moment is we're thinking about research in kind of at least two domains. So there's the requirement for us to publish in peer-reviewed journals, the research papers, but there's also a lot of things we can do as a group of researchers and academics, which is just helpful. So we're running sessions where we pair people with researchers and they spend half a day just being helpful, helping the worker understand things in a more kind of rigorously research-based way. Something about challenges. So recruitment. So this was a big national problem and delayed lots of the HDRCs. So the system of evaluating jobs that all councils have in England has no way of valuing knowledge-based jobs in the same way that you do in the NHS. And lots of us spent months and months liaising with our HR departments, who were very helpful, but we were not able to evaluate those jobs to a point where they were financially attractive to researchers. Essentially, researchers would be taking a pay cut. And so we resolved that by employing the researchers via the university. There are also some problems with the National Institute of Health's understanding of councils. I think it's fair to say they are pretty naive about the nature of the work in councils. For example, they assumed no decisions were evidence-based in councils because they looked at public papers, and as you know, with public papers, they are based in evidence, but we take away all those citations. We present something in plain English. So that's been very interesting to try and help them understand a lot of their assumptions aren't really based in reality. One of our challenges is how we understand the level of interest in doing research. We're developing a baseline survey around that. We're looking at engagement, evidence, consultation, all of those things. As I say, we don't just want to be in an ivory tower publishing papers. We want to be actually useful in the day-to-day work of colleagues. Some of the challenges around the timescale to implement changes. So lots of the things we want to do are fairly long-term. So if you're going to address health inequalities, these are long-term problems, and they often take a long way to work through. But also we're looking to work with Emma fairly early. We were one of the first directors we go to look at how research can better inform commissioning. It seems a quick win to engage with essentially the part of the council that commissions services, we might get a big impact quite early. We've already had some experimental stuff with commissioning the Alliance and some of Dave's work, which is kind of absolutely in line with the kind of things we want to do. One of our challenges is around ethics. So some of you may know this. The ethical processes within universities is, you might say, extremely robust, and on the other hand, you might say almost impossible to navigate. So what the challenge for us in councils is to develop an ethical process which applies directly to research, but does not impinge on the right of the council to talk to its citizens in ways that it deems appropriate. So we wouldn't want an ethical process that stopped that. It wouldn't be acceptable, and that's a novel thing for everybody across the country, because, as I say, the National Institute of Health Research has a slightly uninformed view. Yeah, and obviously we've recently had a change in council, so that we have to kind of go back and do all of that work with all of our political councillors. So our current priorities. So we are developing directorate communications. We have some money to pay for additional capacity for comms, so we're not overworking our comms department. We are finalising a baseline survey for all staff, which will identify who's research interested, who's done research, what do you understand about research, those kind of things. And what we're trying to do is identify champions in each of the 7 departments that can then be seconded to us for 2 days a week to learn more about research, to do research. So there's a parallel process happening via POP with their communities and the charities under their umbrella. We're beginning to develop an evidence bank of the stuff we've already done. So we're looking retrospectively at the 7 or 8 years of appreciative inquiry we have, which is a really kind of rich resource. As I said, we're already being helpful, and we're developing projects for this year. So some of that is building on the pump priming projects. We have 4 pump priming projects, one of which is Rachel's project around food access, food poverty. That will be continuing. Similarly, violence against women and girls, that's going to be a priority area for research. And we're ensuring all our governance is in place, financial management, financial reporting. We've recruited everybody now. We literally just finished doing that. And then the next kind of priority is to try and understand better the cultural differences between the council and the university. They are significant. We're kind of divided by a common language. So there are lots of words we take for granted, which have a completely different meaning in academia and vice versa. And that's just been a very interesting process. So so as I've said, I've covered some of this. Cost of living is a priority for us going forward, and the anti-poverty strategy. All of our researchers went to the recent event at the Guildhall. We went to CMT last week, and we were invited to explore with the Place Department the impact of the built environment on inequalities. So if you think about somewhere like Barton, where there's only one road in and one road out, and no services, those kinds of things. To look at health sector development opportunities for jobs, essentially well-paying jobs, which we can do with the Science Park. And as I've already said, we're looking to influence the procurement cycle, because that's a really kind of key thing. And we've also been invited to liaise with the Children's Directorate about a range of projects, which is we're all really excited about. So that's the end of the show. If anyone's got any questions.
Thank you very much, Gary. Well, it's amazing, isn't it, how things move on and different projects come forward, and I think it's an exciting time, really. Ruth, did you want to say anything, or are you happy to leave it at that?
If I can just say a couple of things. First of all is that this is a really prestigious award, and as Gary says, it's quite difficult to get NIHR grants anyway, but the award to actually develop the council and our citywide understanding of that it's a different element of research to the research that you normally hear about, because it's as Gary said, it's very easy to measure the impact of taking a tablet on a group of people, because they have the tablet, they have they have a placebo, and you measure the difference between them. But what's really difficult are all that stages that get up to the point of actually taking the tablet. So if you relate that to something like stopping smoking, or reducing statins, or hypertension, or any of those things that we can easily understand, but then if you even broaden it more widely to that sense of, so why are on average females in Plymouth having a younger point where they stop being healthy? Those big questions we often don't have the research tools to actually answer. And so this is going to be about developing the research tools to help us to answer them, and also to help other people to understand that the research that we may get out of this is not going to be a randomized controlled trial in the same way as some of the research they're used to looking at. But we need people to understand that that doesn't make it invalid or less worthy in investing in. Because that is a challenge, showing the return on investment in things that affect the wider determinants of health, that prevent things from happening, is so much more difficult than making a strong case for something that treats a problem that already exists. And so this will be helping us in that process. And I think it's a real coup for the city in getting this money invested in us to help us on this journey. Thank you.
Thank you very much indeed, Ruth. Any questions, any queries from anybody? I was waiting to say Jemima.
No, Ruth kind of answered the question about how prestigious it is that we're one of these 10 areas that's got it. I just wondered what the cycle was in terms of reporting back to here or other places or other committees in the council and stuff about progress.
Thank you. Ruth?
Shall I? Yeah. So we are a programme under the City Transformation Programme, City Council Transformation Programme. So we report into the Change Board, and we will be updating the Change Board regularly, probably 3 monthly, but certainly with an annual, summary of the work that we're doing. We would very much like to keep updating the Health and Wellbeing Board, and perhaps an annual update would be really helpful. If we could do that, but we would also we'll continue to liaise with the chair when there are perhaps projects that are beginning to become interesting, that we think maybe should be discussed at the Health and Wellbeing Board. But in terms of that sort of the programme, it would be really, really great to be able to give an annual update here. Thank you.
Thank you very much indeed. Yes, so if we put in that there will be an annual report from them, and as you say, as and when projects need to come for our information, that would be gratefully received, I think. Thank you very much. Gary, thank you very much indeed for coming along, and thank you, Ruth, for your input in that. And obviously, we look forward to hearing more, and certainly it's a field that is developing, and new ideas no doubt will come to you and be put to you by various. I have visions of you being so overwhelmed with this, that and the other. You know, you're going to have to think very, very carefully about what you do and what you have to say, sorry, outside of what we can. So thank you very much, and we'll hear from you soon. So I need to ask the Health and Wellbeing Board if you are happy to note the report. And we will move on. Thank you very much indeed. Okay, now we're going to go back to the original agenda now. So it's a vaping report from children and young people. So Dave, thank you very much, and no doubt Ruth, you've got something. So I don't know if you want to open it, Ruth, before we hand over to Dave.
Yes, that's great, thank you. So I think we brought a position statement to the Health and Wellbeing Board in 2019 around vaping, and the particular reason for that was that vaping has a very important part to play particularly in supporting people to stop smoking. It really is proving to be a very valuable tool in people's journey for stop smoking. It may be part of their formal smoking cessation journey, as in when they actually actively wish to stop smoking and therefore go and get help. It is part of our formal offer, but it's also something that we're finding people are switching to on their own. They're switching to all informally, so we wouldn't know that they're trying to stop smoking, but that is the mechanism that they're doing. And we know that that is absolutely to be encouraged, because stopping the use inhaling, burning tobacco products is very, very dangerous. Vaping is far less so. And so if you're a smoker, we absolutely want people to switch to vapes to stop smoking as a mechanism to support them in that. Some people will just stop smoking. Many people need a bit of help. So we know that. But obviously the whole arena around vapes is really quite contentious, and there are all sorts of different angles to vaping. And we wanted to bring to you some work that we've been doing, some thinking that we've been doing, in particular around vaping in relation to children and young people. And there's quite a lot going on in this area at the moment, and we know that there's been a review, consultation and review that's being carried out over the summer, which we expect to result in some changes to the legislative environment around this. And what we wanted to do is to just have a sort of a conversation and present to you some of the things that we know about vaping and children and young people, and to have started and sort of opened up some of that conversation. So Dan and Dave have been really heavily involved in elements of this, from a vaping point of view, smoking point of view, and a children and young people focus. And so I'm going to hand over to them, if I may, to fill you all in.
Thank you very much. Who's going to kick off? Dave? Okay, thank you.
Yeah, so I'm going to kick off, and we're going to have a quick look through some of the issues around vaping in relation to children and young people, and then Dan, who's our department lead around smoking cessation, will talk us through some of the issues around the use of vaping as a public health tool. So if you want to bring up the slide, Dan. So I think there we go. So what I want to do is I just want to kind of highlight a couple of issues around vaping in children and young people. What I would say is this is an extremely complex issue. It's not straightforward, and the consultation findings that Ruth was referring to, I think, seem quite imminent, actually, in terms of the findings of that coming out. So bearing that in mind, and the whole world could change in the next week on that basis, this is where we are. So a key headline kind of notion to understand is that in terms of children and young people at a population level, smoking rates are down and at the level, a low level that they've never really been at before. So they're very low. However, vaping rates are going up. And that's not a simple A plus B equals C kind of concept. But it's bear that in mind through this whole discussion. Some of the key things that come through from surveys that are undertaken about where do children and young people get vapes from, it's pretty close, but the number one kind of source are shops. Again, we refer to sort of some of the legal issues around this later on. But the next kind of source is from friends, and that would be as you would expect it, really, from amongst children and young people. I mean, if you think about alcohol, and alcohol is illegal to sell alcohol to under 18s. Where do young people get alcohol from? So there are kind of those networks and routes that people utilise. For those that had never smoked, why did they try it? Well, one of the big reasons is to try it. So it's kind of experimentation. Flavours comes up second, and you'd probably be aware of lots of sort of discussion and heated discussion at times on flavours and also colours and things like that. Well, flavours is cited by young people as the second most highly pertinent reason around why they might use. I think it's also worth holding that for those young people that have smoked, they report that they use vapes for a harm reduction reason and to help them quit. So that's interesting, and I think a population amongst young people that we need to think about as well through this whole discussion. So that's kind of important. The other two big issues, the other key area I want to kind of really push out on is the vaping population of young people. And within that population, we sort of see, loosely speaking, two kind of groups. One is quite a small group that are linked to the use of substances that are controlled under the Misuse of Drugs Act. So they are vaping illegal drugs. Now, disproportionately, behaviour or activity by them can be quite big in terms of like how it has to be managed and the consequences of doing so. But they are a much smaller population than the population that are reporting general use of vapes. And by that, I mean use of vapes that are used for nicotine or flavour based. So these are it's useful to think about them as two separate populations. There will be some crossover, but they may require different thinking, and I think that's important. So for the nicotine and flavour based use, we have seen national reported levels of around kind of 9% amongst 11 to 18-year-olds. For Plymouth, through our school health related behaviour survey, reports around use it's been around 16. Now, I do need to put a big caveat here, is that these figures are reported in different ways, and they probably are quite indicative rather than getting too caught up on the actual numbers. It is probably likely that we do have a higher rate in Plymouth. When you look at all other sort of comparative type of substance use or other issues around, that are linked to inequalities, we are tending to be higher than the average. So that would make sense. I've made the point about the illicit use of substances and that they're a small minority of young people. But one of the interesting aspects about that particular group is, in the main, so not for everybody, but in the main, most of those that we know that are doing this are young people that we know to have multiple vulnerability, and are young people that we may well be concerned with for a whole range of other reasons. It wouldn't necessarily be totally unexpected that they might be trying illegal drugs. Cannabis, THC, SCRA, I'll just very quickly mention that. So cannabis THC is probably the most popular kind of form that might be used in a vape device, and it relates to the psychoactive element of cannabis. Some of you may have heard of CBD, which is loosely known as the medical cannabis, so that's slightly different. And SCRA is kind of people made or man-made a drug. So spice would be an example of that, but it isn't cannabis. It's important to realise that isn't cannabis, it's just another tool for drug, but that's the two that would be used in that kind of area. The other thing I'm going to make out just on this particular slide is factors likely to influence, and I think this kind of brings in some of the complexity that we might be talking about when we think about prevention. So these are some of the key influences that we're kind of aware of, and there might be some further discussion that we want to do around this in terms of work we do over the autumn. But issues around family and peer use and experience, you know that there are children, young people in our city that live in families where there may be grandparents or adults who may have switched from smoking to vaping, and they may well see some of their family's health actually improve. So their respiratory conditions may have improved, they may be able to walk further. So for them, the lived experience of vaping has to be, is in that context. But there are other kind of family and peer use and experiences that can influence as well. Peer pressure and peer preference. Always want to make sure that we're aware that people also want to be part of groups, as well as sometimes being pressured to do things. There is undoubtedly a culture emerging around the use of vapes, and that is a new thing over the last 7, 8, 9 years. And to some extent, we don't really know how that will move forward, but it is a cultural phenomenon. There is an element of identity around the use of it, being part of a group that are doing that. It's worth noting that we see higher rates among young girls and young women than boys and males. And anecdotally, things like not smelling of smoke, clothes aren't smelling of smoke and things like that are playing into some of that. There is a media issue in the way that vapes are portrayed. Media can be very powerful. And then we get into some of the areas that we kind of often get drawn into, which is about access and availability. Well, access and availability is quite prevalent, and everybody knows there's a vast amount of arrays of different outlets for vapes at the moment, and the marketing of them, another area which might be of concern to some. But those things are really important. And I've mentioned with THC and SCRA issues around multiple vulnerability. Do you want to go to the next slide, Dan? I'm sorry about this one, it's got a lot of words on. You will be getting all of these afterwards, but they're an adjunct to the paper you've already got. On the left-hand side, which is the purple side here, these are the kind of areas that we're beginning to coalesce together as a coherent set of prevention messages. It's not easy from where we've started with all this, and that's national, just not just us locally, to kind of identify what that might really be. I'm not going to go through them all here. They're for here to you to kind of maybe just have a look at. You might want to come back with questions later on, but I think some interesting things are stuff like, you know, the evidence base has been primarily drawn from adults who smoke around harmful effects. There are issues around child and adolescent development, and we know with lots of other different risk-taking behaviour that early onset of use is often associated with poorer health outcomes and more difficulty in trying to change your behaviour. So those are the sort of kind of areas that we're trying to work through. And we've been talking with schools around what that might mean in terms of advice for them around prevention and prevention work. And so just sort of to touch on what some of that prevention work, how that might actually begin to look in terms of bits of activity. On the right-hand side, we've got a system support and task and finish group. More investigation to understand what's going on, and to understand what happens in our city as well in a better way. This idea of developing credible information, the importance of having information that makes sense to people in their lived experience is really critical. And although it is very, very easy, I say this on the basis of like being through this several times around drugs over the last 20, 30 years, the importance of information that makes sense to people is really, really important. And there is a lot of noise, and it's a very hot topic. So trying to keep to what we know, the evidence base, and trying to be as objective and based on lived experience is critical. Then it makes sense to people, and then behaviour change is more likely. Support to schools, they've been under a lot of pressure. They've found this very challenging. And they've struggled at times. So I think it's important as a system we support schools. Increased family and community awareness, supporting colleagues in trading standards in their role with regulatory compliance. We have done some webinars already. We will continue to do those. And this issue about support for children and young people who do vape in order to help them minimise risk or stop, I think is an important thing to think about. MDA, which is the Misuse of Drugs Act, substance incidents. So about how we're reporting incidents, partnership support and resources produced. So through incidents we've had locally, we have actually set up a mechanism for reporting these. We have a group of partners across the city that are able to come in and support schools and young people. So we've got part of that in place. We'll have to see how well it works. And as a note, just in terms of children and young people stuff, I'll put this out there just so that we're conscious, because we don't want unintended consequences. I think it's important that we don't help escalation of risk through punitive responses, possibly, that may lead to greater risk of exclusion from school. I only say that on the basis that it's important that we try to avoid that. There will be examples probably where that may happen. It might be more located with illicit drugs being used through vape devices, but if it isn't, having a proportionate response is quite important. So, sorry, Dan. Over to Dan.
Thanks, David. It's probably worth saying that those messaging and system support are picked up in the recommendations. That's at the end of the report that you've got. So I'm going to just expand on what we know about children and young people and vaping now, and then move on to just conclude by talking about smoking cessation opportunities that vaping provide. So I'm going to be brief here. So this is the kind of you can see the increase in vaping that these occurring in the country. This is a national survey conducted by ASH and YouGov, and that orange line there shows that vaping of any type, experimental and regular vaping, is on the increase. It is worth noting that that orange line shows the increase there, and half of the 20% of people who are currently vaping say that they vape once or twice. They've tried vaping once or twice, and the other half is split into young people this is young people aged 11 to 17 who say that they do vape more than once a week, and the others say they vape less than once a week, but they've tried it more than once or twice. So there's kind of half that have tried it once or twice, a quarter that are vaping more than once a week, and a quarter that are vaping less than once a week. So regular vaping by non-smoking children is relatively rare. It is a thing and it is very important, but in terms of the number of people and the rates of vaping, it's not the majority of young people that are vaping that are initiating it like that. This is to build on what Dave said, to show our what we know locally. It's not directly comparable because we asked different questions, and that last survey was 11 to 17s, and these are distinct year groups. But it does show that, I mean, broadly speaking, Plymouth follows the national, the rates which we see nationally. You know, there is you can see there, the year 10 girls have got a higher rate of vape, you know, a significantly higher rate of trying vapes, a vape at least sometimes, and that's a concern that we need to understand. It's a pattern that we also see with other risk-taking behaviours, and smoking, for example. The rates do go up around that year for girls compared to boys, and then they drop. And then as people become adults, we tend to see the other way around. More males smoke than females. So I just highlight the kind of the regulation that surrounds vaping is one of the things that lets us be very confident in what we say about vaping, because the UK has got one of the kind of most stringent regulatory frameworks for vapes. So when we're talking, I'm going to come on in a minute to talk about the evidence and the risks and that sort of thing. When we talk about the risks, when we're talking about the risks from legal vapes that are registered, we can be confident about what's in them, and then therefore the risks associated with them. So there's laws around how the product can be designed, what can go into the vape liquid, and they're registered with the MHRA, the Medicines and Healthcare Regulatory Agency. There's also laws on age of sale, so it's illegal to sell a vape to anyone under the age of 18. And there's laws about targeting young people with explicitly targeted adverts that target young under 18s to vape. So there is a stringent regulatory kind of environment for vapes, and they are more controlled in the UK than they are in a lot of other countries. And locally, you know, our colleagues in trading standards use those laws, and they do work to build compliance with the laws in Plymouth. So, and that's an ongoing programme that they've got. So there's some details there about what the work that their team are doing at the moment in Plymouth, and it's an ongoing programme. So they'll continue to carry out these kind of this sort of regulatory work. Key thing I think probably worth highlighting is their test purchase operation that they undertake. So you can see there they've carried out test purchases in Plymouth this year, and they had 2 failures of sales. That means they got a sale when they sent a young person in, and that's resulted in further investigation and further action. 3 that's warning letters, 3 SWR, sorry for the jargon there. That's the warning letters that are sent out, which is in line with the trading standards enforcement policy that they would send a letter out in the first instance. So not only do they undertake test purchasing for underage sales, they also are involved with illegal vapes that are non-registered. And as Dave's touched on, the kind of vaping of illegal substances in vape liquid is an important key issue, because we can't say what we know about the risks about that, because we don't know what's in them. They're not registered, and there's no kind of we can't rely on what's in them. So the Trading Standards Service, in the same way that they seize illegal tobacco, they're out looking out for illegal vapes as well, and they seize illegal vapes and take legal action against people who they catch selling it. And I've talked to colleagues in trading standards, and they've highlighted that they've got the positive relation. They work closely with the police in Plymouth, and they feel confident that they collect intelligence, they turn it into kind of actionable intelligence, and then they use that to form the basis of their operations, so they can target their operations to where they think there are more issues. Sorry, I'm just on. So I'm just going to talk now about smoking cessation and vaping as a smoking cessation aid, because it's important to understand, as Ruth and David have said, children and young people vaping is an important key issue, and children who don't smoke, who start vaping, are one of our important population groups that we need to bear in mind. The other one is adults who do smoke. So, and vaping is reaching adults who smoke much more, many more adults who smoke than most of the other options that we've got. So you can see there, that green line shows the growth in vaping as a smoking cessation aid compared to what are our traditional methods of nicotine replacement therapy and behavioural support. So vaping's growing in popularity, and it's by far the most popular method of giving up smoking. And not only is it the most popular, now that we also know now from recent research, it's up there with the most effective as well. So it's an important intervention. And again, one of the reasons it's so important that we have a clear position on vaping is this slide here, which is a bit busy, but I'm just basically highlight it, is that the adults and children and young people generally misperceive the relative risk of switching from smoking to vaping, and that misperception is is growing. For a number of reasons, it's a complex issue, but the way that vaping is presented, in the media and as an issue, some of that is driving the misperception. So it's important that we get the position right, so that we don't do harm with our position, we don't increase the misperception, we counter it. And you can see there, the orange line there is people who think that e-cigs are less, or correctly think that e-cigs are less or a lot less harmful than cigarettes. And that rate of people who think that is declining, which is a concern for public health and for us generally. That doesn't need to decline, because there will be adults who may have quit if they understood what the correct risk is. And there also may be children who smoke or who grow up to smoke, continuing that misperception, who might have quit through vapes, that don't, if they've got this misunderstanding about the risks. So there's a lot in here again, but I'm just going to highlight this. This slide covers the risks, and this is the government summary of all of the evidence, systematic review they've done of the evidence. They've been doing this systematic review since about 2015. The only change in their position about the risk about vaping is that we've got more certain about what we say about it. So back in 2015, we knew that vaping was a lot less risky than smoking. The reason being because it doesn't have tobacco in it, which is what causes 95% of the harm. Burning the tobacco with it is what causes 95% of the harm in a tobacco cigarette. Vaping is just the nicotine. So we've known potentially that it's a lot less risky. We've known it since 2015. All the robust evidence that's come out since then has confirmed that. So that we are more sure now of that than we were back in 2015. This is again, so you may hear, we do hear that we don't know the long-term impacts of vaping. Commonly hear that. There isn't research which has studied the long-term impacts of vaping on non-smokers, as Dave says, and children particularly, partly because it's such a small group. Most people who vape are either ex-smokers or they smoke and vape at the same time. So there isn't evidence like that gives us an indication of the long-term impact of vaping. But there is evidence from what's in an e-cigarette. So there is published research that shows that basically analyses the contents of a vape, and it puts vaping next to nicotine replacement in terms of its risk to health. So this is a chart that shows smoking on the far left, rated at 100, against 15 nicotine product categories. In other words, chemicals that go on to cause harm. And you can see on the right there, e-cigs and nicotine replacement are next to each other in terms of the concentrations and the presence of harmful substances. So it's, in terms of risk, it's much more accurate to think of vaping with regulated nicotine-containing e-liquid as similar to nicotine replacement therapy, which is what we give to people by prescription to help them to stop smoking. And this is again risk, highlighting that they're sort of picking up what we know about the risk in terms of vaping. And these are the reports. Vaping is a reportable substance. E-liquids are reportable to the MHRA, and they collect data on reported adverse events. And these are all the reactions across the country, across the 3 or 4 million or so people that vape a year. These are the number of reactions they've received, number of reports, and then 5 fatalities potentially associated with vaping. The caveat is, it's not that there's a proven link between those events. It's that they got a report. They got a report that potentially suggested an association between vaping and those events. Nearly. I'll just round up with a couple of slides. Just to highlight, vaping is a key issue, a key tool that we've got with our stop smoking service, and we do offer vapes alongside nicotine replacement for over 18s who want that sort of support to give up smoking. And it is absolutely, I can say for definite, there are people who've stopped smoking because we've managed to offer them a vape who wouldn't have stopped smoking otherwise in Plymouth. So it is a really important offer, part of our offer. And we are also broadening out that offer now to engage with people with more complex needs and challenging lives. And again, we're getting really positive engagement rates with people. So a lot of people with complex needs and challenging lives who I can guarantee wouldn't have engaged with our traditional stop smoking service that are engaging with this harm reduction offer of a vape to help them to cut down and give up smoking. So again, the story is the same in that group. There are definitely people with complex needs and challenging lives who are seriously cutting down the amount that they smoke, the tobacco they smoke, and replacing it with vaping who wouldn't have done otherwise. So there's a summary. So what we're really trying to say, what we're really saying here is that our position on vaping needs to balance the risks and benefits associated with vaping for young people and for people who smoke tobacco. We know that vaping with regulated nicotine liquid is considerably less harmful than smoking tobacco. We also know that the illegal market in vaping has got no controls over the age of sale, so it's more likely to be sold to young people. It's got no controls over what's in the content, what's in it, so it's more likely to be significantly more risky. And that's why it's so important that we enforce and police that area. And we also know that switching from smoking to vaping is the most popular and effective way for people to cut down to stop smoking. So I won't read through that, but these recommendations are in the report that you've had. So we've got kind of 9 recommendations about how we propose the position that the Health and Wellbeing Board takes on vaping.
Dan, Dave, thank you very much indeed for that. We've got the recommendations there. One of them I'm going to ask us to change because it talks about a task and finish group. Now that is of councillors. Task and finish group. So what we have to say is a working group, because I want it to be of this body rather than scrutiny, if you see what I mean. Because I mean, to me, one of the agencies we ought to be asking is certainly the police as well as our trading standards. I mean, I think that's got to be interesting as to who we have on the task and finish group. So I think that's as I say, let's change it from a task and finish to a working group. Are you all happy with that amendment to it? Yep. Okay, thanks. So any questions for Dave and Dan? Natalie?
I think we spoke about the fact that it's illegal to sell to an under 18. My concern, and from things that have been said to me, is, you know, it's where adults, because it talks about friends supplying, but, you know, how much evidence have we got of adults, potentially family members, buying vapes for young people under 18, you know, things that I'm being told about, and I have been told about, you know, somebody that observed, thankfully, somebody in a vape shop refusing to buy because the adult was going, and what flavour do you want? You know, and yeah, that it's plain that that's not going to be used by the adult, it's going to be used by the young person. So what's being done, and how are we working with, you know, police, whoever, to make sure that adults, family members maybe, are not buying for the young people, thinking that it's a better option.
So I think at the moment there's sort of anecdotal stories like that, yeah, and I think so technically speaking, the law is selling to an under 18. It's not giving to or providing through that route. So as far as I understand it, technically speaking, that isn't against the law. And we also need to remember, so it's not illegal for an under 18 to vape. So there are approaches that I think can be undertaken. Different areas will be in different places. I think part of the work of the group would be to get an agreed approach around something like that. I think there is quite a lot of opportunity around raising awareness around some of the gaps in the evidence base and trying to find ways of being able to articulate that so people can simply understand that there are a couple of unknowns, maybe. So that the evidence base is based on this but not on that. So yeah, I mean, I think we're in a place where this is quite a moving, dynamic, hot topic. It is not easy when there are part of this is a message that there can be some value to it. It isn't easy, and then part of the message is that, oh, hold on, that shouldn't be happening. So that it's difficult. So I think we have to. I think part of the work of the group is to get a message which we can work through, be consistent, and keep at it for several years. I'm not sure about how. When I say that, you know, that there may be some quick wins. We might not know what they are, but I think it's about trying to be consistent over a long time. Would probably be the best thing in terms of the prevention measure there.
Just to add to that, it's good that you highlighted the responsible retailers, because that is part of the answer, is the support that we can give to responsible retailers in the city, and that there is a buy with confidence, trading standards buy with confidence scheme, that those responsible retailers are, you know, some of them are signed up to and they can sign up to. That's one way we can make, you know, we can kind of improve the situation, I think.
Thank you. Jemima, then John.
Thank you. Dave, you've kind of touched on one of my points about the thing I can't get my head around is that, you know, there is a great deal of concern about this. I understand from a public health point of view that this is, you know, this is preferable. It's always going to be preferable to smoking, isn't it? You know, and I just think it is something around the message that's the difficult thing, because it's not the same as saying don't smoke. It's saying there are benefits to vaping if you're a smoker. And I think it's number 5 in particular that I really feel we should be highlighting, because I know people in my own family who vape, who've never smoked. That might not turn out to be a problem in the future, but it's a strange thing. It's certainly not been a preventative thing. They've taken the choice to vape and have never, ever smoked. And also I do think, and again, I suppose this is a public health thing in a way, in terms of just the waste it produces, just in terms of our environment that we live in and all that kind of thing. And I just, you know, it's probably not as high a priority as any of those, but I do think that should be part of what we think about in terms of how the waste that it produces is disposed of.
And certainly government guidelines is saying that if you sell particularly single issue vapes, that you should have a disposal system there in the shop. But we all know that doesn't happen. They perhaps don't ever go back to that same shop to get the new one and take the old one with them, sort of thing. So yes, I think again in the local government chronicles and whatever we're seeing about our bins setting fire and all of this lot. So it's going to be quite interesting to see how this goes. But certainly, yes, it's the thing of this sort of era at the moment, isn't it? It's perhaps being seen as being safe and whatever, but as you say, Jemima, it's that fifth one that is one of those challenges, isn't it? So yes, Dan.
Sorry, could I add one thing I meant to say as well? It's about the online sales.
Yes, it's less that I thought the online sales were going to be quite high, but the latest information I read, in fact, it's quite a small proportion online. It is still that going into the shop to get it locally that it is higher, isn't it? Much, much higher.
Yeah. Online for nicotine.
Can you put your mic on, Dave?
Online for nicotine and flavour-based vapes would be very, very small. It will have a role to play in terms of accessing substances controlled under the Misuse of Drugs Act, as will kind of normal supply lines of illicit drugs. So again, but think about that in a different part. But yeah, it's not quite as big. It is much more about, I think, kind of the prevalence now of access, like in so many different places. So.
But just because it's not high now, sorry, Chair, doesn't mean it won't be in the future or it won't grow. In just terms of our position and the recommendations.
I think it's always worth noting that that if government decide that there needs to be more stricter and stringent regulations here, you often get a reaction here. So it doesn't mean that you'll get another complete illicit market the size of what's being managed here, but things will happen. So we do. It's a moving thing. So we need to have the capacity and capability to have the insight and the feedback and understand what's going on and use that intelligence to inform what we do.
Okay, thank you for that, John. And then I'm going to close because we've got a certain other officer sitting there who's been very patiently sat there. Okay, John.
So thank you for that presentation. So really, the problem is with the illegal vapes, the unregulated, dangerous contents, and it becoming a fad, a phase that young people or even older people think it's going to be the trendy thing to do. So that, vaping is fine for those who should be doing it to get off cigarettes, but for everyone else it is not. Is that the message? Yeah.
We will see what this working group comes out with. But as you say, I think it will be an ongoing working group that will need to have, once it's had that initial interim report, I think it will then need to update. Okay, can I thank you both very much indeed for coming along, and an interesting topic that we would need to deal with. So I need to ask you, please, folks, there's the recommendations that are there on the front of the report. I'm not going to read them all out, but with the proviso that we alter that task and finish to working group, please, that we adopt the following position on vaping and e-cigarettes. Are you all content with that? Okay, thank you very much. Thank you, team, and we will be in touch, because I think the sooner rather than later that we get something sorted out. But I will have another conversation with you about the other thing. All right, thank you. Right. Okay, so we come back to the last technically agenda item. Really, it's the dental task force update. I'm going to hand over to Rob, because simply he can be very much more succinct than me waffling on. So I'll hand that over to you. Thank you.
Great, thanks, Chair. I think I won't talk for very long. It's a really short paper. It just summarises the work that we've done at the first meeting. The other benefit, I suppose, is that the majority of the people in the room and online in this meeting are actually involved in this agenda anyway, so know quite a lot about it. So to some extent, it's I'm telling you about something you already know. But just to take a step back and just highlight again why this is so important. There are currently, over now 22,000 people on the waiting list trying to get an NHS dentist. Plymouth residents, that is, who are trying to get an NHS dentist. Got lots of children with visible tooth decay. We've got, and one of the big issues that we've highlighted over the years is the fact that we have over 600 Plymouth children having over 4,000 teeth removed between them every year. So as a result of that, the access to NHS dental care was made one of the priorities of the Labour administration, and as a result of that, it was decided that we would set up this dental task force. Councillor Aspinall chairs the dental task force, and I, along with others, do a lot of running around in the background to support Councillor Aspinall with that. What we have tried to do, the priority actions that we're trying to do, identify sources of funding that can be used to address this priority. We know the source of funding for that. We're just trying to get it back from NHS Dev and ICB to be spent in Plymouth. It is the thing we call the dental clawback, the underspend on high street dentistry. We're trying to get that. That money is now ring fenced, okay, so it can't be spent by NHS Dev and ICB on anything else. But what we want to make sure of is that Plymouth's share of that money stays in Plymouth to be used to support Plymouth residents. That's the source of funding. The easy bit was identifying it. Getting it back in the city is the challenge. There are planned developments that we've identified that the Dental Task Force have talked about that can be taken forward. I can give you two examples quickly now. The dental school have had an ambition for over 4 years to establish a city centre dental practice that would take 3,500 residents just like that off that dental waiting list. We can prioritise those residents being because we've got that information in terms of the waiting list. So it wouldn't be fast come, fast serve. We could prioritise the most needy residents to be taken off that waiting list. I don't like using the word needy, but I'm just trying to talk really quickly to summarise a load of things. We've also got something which we're not going to allow to drop off the agenda, which was the 5 dental chairs that were planned for the Cavell Centre. Although the Cavell Centre itself is not going forward in its originally envisaged form, there was a plan to have 5 dental chairs in that building. Now, we as a local authority and a set of partners could decide that we want those 5 dental chairs elsewhere in the city. So the point I'm making is, if the funding was there for them originally in one spot, we could potentially consider putting those dental chairs in another spot in the city. So we want to just keep ploughing ahead with that furrow, if you like. There are other dental and other providers of NHS dental care in the city. We're working with them to find out what capacity they've got to deliver additional services. So there's an awful lot going on. We agreed 11 actions at the first Dental Task Force meeting. The second Dental Task Force meeting is taking place tomorrow, and we're going to have a follow-up from everyone who agreed to take forward one of those actions. That we followed up at the meeting tomorrow to find out what is going on with those actions they agreed to take forward. Since the first Dental Task Force meeting, it's clear that NHS, Dev and ICB are taking this issue seriously, because they arranged a Plymouth Dental Investment meeting. And that took place a couple of weeks ago. Myself and Tony were at that meeting. I think we were maybe a little disappointed with the conversation at that meeting, because all of the dental providers in Plymouth were invited, so all the high street dentists, not just NHS dentists. And I didn't get a feel that there were any massive things that they thought they could do that would suddenly address the dental waiting list issue. It was much more about little tweaks around the edges. But we've got to let that run its course, because the ICB have decided to take that as their way forward. So in terms of how that's going to happen, that dental investment meeting, the ICB have asked that within 4 weeks, so 2 weeks to go, so within 4 weeks' time from that meeting, that providers of NHS dental care in Plymouth come back to them with suggestions for how they can improve access to NHS dentistry in the city. Those suggestions will then be fed back to the Dental Task Force, and my hope is that we will then decide how we prioritise those. And that's pretty much where we're up to. Dental Task Force meets again tomorrow, and I think if I was to recommend anything, it would be that we keep coming back to this meeting with updates for you, because it is an agenda item that you're all invested in. That's probably enough.
Thank you. Ruth, did you want to say anything, or are you happy to leave it at that? Excellent. Okay. Any questions? Jemima?
Thank you. I have to say that there are lots of reasons why I'm pleased that we are now running the council, but actually the dental task force is the thing that I am most pleased about. I know Mary has campaigned on this for a long time. I've campaigned on it for a long time. It's a real priority for the city, and to see those actions from the first meeting was really gratifying. And Mary invited the city's MPs to be part of it. It's a cross-party thing, because it's a thing we've got to get sorted for our residents and our city. And I was a bit shocked when I heard what the clawback was. And am I right in thinking it's somewhere between 7 and 9 million?
So we've got what we've asked NHS Dev and ICB to do is come to the meeting tomorrow with the exact figures. So historically, it was thought to be about 1.5 to 2 million, but it's likely to be more than that. The number is massive. It's off the scale when you think about what we could do with it and what those providers are asking for to make that real difference in the city. We've got to give you a concrete example. Well, the dental school, they're asking for £250,000 a year to take 3,500 people off the dental waiting list out of a clawback of £2 million, at least £2 million, maybe up to the figures that you're talking about.
So I think for us, that's very hard for our residents who are doing DIY dentistry, or another group that I've asked Mary to raise at the Dental Task Force that has been raised with me is around women who've just given birth who are not able to access the NHS care to which they are entitled by dint of having given birth recently, and the effect that has on them and their teeth. It's very, very hard, and I'm sat next to someone. ICP, to say to residents, actually, yeah, sorry you can't see a dentist, sorry you're in pain, sorry your child's having to go into Derriford to have teeth removed under anaesthetic because they couldn't get dental care. But this money exists. It's just around ring fencing and frameworks and what we do with it. And so I don't mean this to be a negative contribution. I'm really pleased that within one meeting we've identified things, and things are moving, and meetings are happening that weren't happening. I just absolutely implore the people who have the levers and the ways of releasing money to do it, because it's indefensible to tell our residents that the money exists but we can't spend it on you.
I think that's why it was so important to make it the movers and the shakers, and include the MPs. And even though Sir Gary couldn't be there last time, he made sure that somebody went with it. And I must admit, I'm hoping that will happen again tomorrow. Certainly I've had acceptances from 2 of the 3 MPs. So again, it'd be good to take it forward. But yes, I mean, it's one of those things. I mean, so many illnesses arrive from having poor teeth and, caries and whatever. So I think this is, to me, is why it's important. And I think there's going to have to be a new NHS dental plan, and we need to be making sure that that's effected. And certainly I know that Luke Pollard has spoken with the person that's preparing that dental plan and making sure that he knows where we're going with this. So I think that's what, to me, it's these tentacles that we're putting out there and making sure that we reach that. And I mean, John's on it as well, so that's really useful. But yeah, so we will report back in January to you again, which I think that's where we want to leave it today. But Rob, thank you for all of the work you're doing on it.
I mean, just to say one final thing, if that's okay, Mary. I think what we've got now, certainly within Plymouth, and it's almost moving into neighbouring local authorities as well. We've got pretty much every councillor, every partner is 100% behind this agenda, and all the officers like myself who are involved in it are absolutely not going to let it drop as well. So if we can't make it work with that momentum behind us in Plymouth, it won't work anywhere.
Totally agree. Totally agree. So thank you. So we're asking you that you note the content of the report and you continue to support the Council's corporate plan priority of working with the NHS to improve better access to health care and dentistry. Thank you very much indeed. Okay, tracking decisions. Elliot, that's your
Yes, thank you, Chair. So members will see there's 3 tracking decisions now marked as completed on the tracking decision log. The first one was the workshop we held on the integrated care strategy some time back. The next one was the circulation of the Plymouth report that we heard here last time. That's been printed and put in your group rooms and also circulated online. There is a slightly wider side to that to be picked up around circulating that to council organisations we work with, GPs, universities, things like that. And I'll work with Ruth or Rob on that one. And then the last one that's been ticked off was the defibrillator funding link, which was circulated and put in the councillors' bulletin. So we've got 2 that remain active on the log. The first one is the 7 defibrillator recommendations referred to us from the Health and Adult Social Care Scrutiny Committee. So a reminder to organisations and colleagues here to continue promoting those, although I think Mary and Ruth might want to say a few words.
One of the things that we also brought up was that we wanted to make sure that all our partners advertise the defibrillator, registering a defibrillator day on the 15th of October. And my understanding is that, Ruth, that we're going to see about, one of the other recommendations is about counsellors being able to learn CPR if they wanted to, and we're going to link that in with that. And obviously that will be a voluntary thing to do, but even if you don't actually do the practical thing, learning and listening to how you do things will be useful. So Ruth, I don't know if you can confirm that. And the other thing that we needed to confirm was we're going to definitely be putting a defibrillator on the Guildhall. Now, Ruth had some homework yesterday to quickly find out if we could find out what the situation is there, because of course the Guildhall shuts in a couple of months anyway. So I didn't know whether that was holding up the process. So Ruth, I don't know if you want to make any comment.
We're focusing quite a lot around the Restart a Heart campaign. And as you say, there is part of that includes CPR training, which is available for everybody to do. It's less than 15 minutes and you need a mobile phone and a pillow. Now, not everybody has that, we know. And so we're looking at other opportunities as well. But realistically, we're probably not going to have all counsellors in a room at a time. So we're looking at opportunities where that sort of Restart a Heart training can be done out in communities and pushing that at the moment. And yes, I'm sorry, I don't know the update. Certainly the agreement has been made that we'll have the defibrillators all put in as per the paper. I don't know where colleagues have got to in terms of physically putting them in at the moment. I don't think we've had a response to that.
Thank you. And I think we are still working on partners providing a defib at St Budo Library and Southway Library. And I think that's one of those actions. I think we'll make sure that we are sort of chivying and thinking about likely partners that might well help us in that. So we'll have another go at that. Okay. Thank you for that, Ruth. Right, that brings us to the work programme. As you can see at the moment, there's very little on the work programme for the 18th of January. And I've got to say, after causing aggro last time about changing dates, etc., which we then didn't need to do, the 18th of January actually clashes with the Adult Safeguarding Board. So that will need to be moved. And Elliot, we sort of looked quickly through the diary, didn't we, to see what we could do?
Suggested a date of the 18th moving to Thursday the 25th, so that's 1 week later, and it would be from 2 to 5 p.m. I'll circulate that by email, and if it's convenient for chair, vice chair, and key members, then we'll go ahead.
2 till 5, hopefully, because there's something on in the morning, but there's the afternoon, if we can, and if people will do that, that'd be really, really useful. The only other thing I could look to is changing the day of the week, which I think sometimes it's more difficult to do than to move the timings. But if you can all look at it, we'll send out something after today, so if people can check their diaries to see if you can squidge that in. I mean, it is sort of 3 months away, isn't it? So that would be useful if you can. Okay, so at the moment we've got a vaping position statement. Now, whether we're going to be ready to bring that, I don't know, Ruth. I think we just need to see. But I think then we need to look at what else we can bring into that, because it's certainly not worth having a meeting for just one thing, is it? So we'll look and come back to you with some agenda items. And if you've got agenda items, please let us know. Okay. Right, so is that the end? She says. Yes. Thank you all very much for attending, and I apologise that we've gone on a little bit, but I think we've got a huge bit of work done in this session, these sessions. So thank you for that, and I suppose it's not too soon to say to somebody happy Christmas. Oh, yes.
Oh dear, Mary.
Take care, and we'll see you soon. Thank you, folks, and we'll be in touch about the working group, because obviously we'd like as much of sort of representation as possible. So we'll look to some dates for setting up the first one for that. All right. Thanks very much.